doing this meeting live stream on YouTube for other Apollo Hospital participants who want to join. So the speakers are requested to be, adjust their mics. So good morning, I am Dr. Snehal, clinical geneticist here at Apollo Genomic Institute. We have genomic unit which started off, and now we are arranging a comprehensive service in each specialty. So as we go along, we just thought that we will have a specialty-wide genomic awareness, because the genetic investigations applications are becoming precise and widespread. But also every specialty, the applications may be different, and hence we are doing this awareness session specialty-wise. Dr. Rashid Merchant, who has inspired this clinic, Dr. Gauri is there, who is a genetic counselor. Dr. Parag is there, who is a visiting consultant here as a clinical geneticist. And we are trying to make this meeting reach many of consultants from Navi, Mumbai and outside, trying to get them here. And Merchant sir keeps saying that we have to have a good audience. Let us say by the time we go along taking each specialty, how much we'll be successful. But today we have excellent faculties to speak on. Initial, we have 2-3 lectures. The theme of this genomic awareness session, we want to keep case-wise discussion, but at least for few sessions, we have some experts talking on this subject who will have an overview of that specialty. So today we have Perinatology Genomics, where it is applicable to pediatricians, obstetricians, fetal medicine and radiologists. Few will be joining soon. From other specialties also, radiology and obstetrics, they are on their way. And there are multiple meetings today also, fetal medicine, obstetricians. So some are going to join for case discussion and panel discussions, where we have involved some medical colleges and institutes out in Navi, Mumbai. So I welcome Merchant sir. We know all, but still for students, he is a senior pediatric consultant with very special interest in genomics. Trying to push hard till it established in Apollo. Sir comes here as per appointments. So he's a big CV, ex-dean of Wadia Hospital. Everybody knows him, sir. So he is going to give us an overview how he looks at perinatology care and how it evolved in his whole career from just looking at fetus till genomics. Sir, I welcome you for your talk.
Thank you, Snehal, and thank you, Gauri, and thank you for all those who are here. For those Hema, and for you, those who are into genetics, may not know that in 1979, I did a course in genetics at Great Ormond Street with Professor Cedric Carter. I mean, those who know anything about genetics and the senior here would know his contribution to genetics. Professor Cedric Carter and Professor Marcus Penbury. Dr. Kumta and I were the two people who were representing India in that British Council meeting. So, really, I keep on saying that genetics is the future of medicine. And genetics is the future of medicine. And we are very fortunate that at least at our institute, at Apollo, we've been very fortunate that we've had excellent stimulation from our management, starting with our joint medical director, Professor Anupam Sibbal, and all the administrative people in this hospital. They are not here. I'm going slow, hoping that some obstetricians might trickle in. I thought this was an obstetricians meeting. So, Santosh Marathe, Dr. Kiran, Dr. Colonel Ravi, they've really been so helpful to us. And rather than putting me as the main cog forming this genetic center, because I don't know genetics. I'm learning genetics. I'm in the process of learning genetics. Mind you, I went into medical college in 1963, madam. I joined medical college in 63. A bar Bertram body was the only thing that we knew in 1963. And in 69, when I joined post-graduation, there was nothing on genetics in our books, and so we didn't know anything at all. So it's been a long ride since then, and we never really studied genetics. And I've had the opportunity, and I say the good experience of having to work with Parag and with Dr. Snehal, and of course Gauri, who is our counselor. So as a team, we are trying to do something to make awareness of genetics, and just to know how important genetics really is. Where do we go from here? Yeah, but how do I go forward? Yeah. This is going forward, all right. And this is going back? Yeah. All right, so this talk I am dedicating to my teachers, really, and my students. And my students have been undoubtedly my greatest teachers over so many years. And if you can see the book that my book, which is there, which is still turning pages. So we are still trying to learn and fill up and learn genomics. Right. As far as my teachers were concerned, these, and I make it a point to show the pictures of some of our really great teachers. I mean, these two gentlemen trained more than a generation of pediatricians. Professor P.M. Odani from JJ, and his prodigy, Dr. YKA, and his prodigies, and then Dr. S.M. Merchant, my guru. He's gone 32 years, but believe me, I still dream of him ever so often. And he's in my dream telling me, Rashid, I barabar tu nati karto. This is not the right way of doing it. You better do it this way. And we are taking rounds in the ward. So after 32 years, this man is still, part of my life. That just to say that, great teachers that these were. And I'm spending a few minutes because it's so important to have good teaching. We cannot spread the word of genetics unless we have good teachers. We must have great teachers, and we had great teachers, and they taught not from the book, they taught from the heart, and that's where we learned our pediatrics. Now, since we are talking about perinatal care, I just wanted to, are there any obstetricians in the meeting here already? Are there any obstetricians here? Yeah, nice of you guys to be here, but it's actually meant for us to interact. And I just want to mention that this perinatal care, which has been the need of the hour for the longest of time, in this age of perinatal genomics, are we as a group together doing enough to help to spread the word of perinatal genomics and genomics itself? Now let me tell you, where does that go? Right. So as I said, it is the need of the hour. So what indeed is the need of the hour? And we have always spoken this for the longest of time, that we need to reduce the aim of having perinatal group meetings together, and we used to have at the Wadia group of hospitals monthly meetings, mortality meetings, and morbidity meetings. And the whole idea was to bring down maternal mortality, neonatal mortality, and perinatal mortality, right? And I think to an extent we were able to be successful in doing that. And that was because now we have got a large number of level 2 and level 3 NICUs. I'm sure all centers now have level 2, level 3 NICUs, which were not there in earlier times. An important part which has helped has been the importance of neonatal transport services. I remember babies coming in to us at Wadia Hospital at all hours in the night as cold turkeys, completely cold. I don't know how the services now are, say, at Panvel, but I know that at least in Greater Bombay, the services, transport services have now improved a lot. And I think that has helped in reducing the NICU. You'd agree with me being a neonatologist and things like that. Preventing prematurity and indeed trying to prevent fetal growth retardation. Now let me tell you that over the years, Dr. Ajit Mehta, who started the whole ball rolling somewhere in late 80s at Wadia Hospital, and then he told me to start taking out the data from the past. We looked into, and we kept on looking right up to 2020 and even on. We found that the prevalence of IUGR, growth retarded fetuses, had not decreased. So, obstetricians, please do not take any credit. You all have reduced NMR, MNR, you all have reduced neonatal mortality, largely because of good fetal and neonatal care. But the prevalence of growth retarded fetuses, for some reason, in spite of FLASP, in spite of giving aspirin, in spite of everything that we have done, we have not reduced. So our first aim, I think, would be to reduce NMR, PNMR, and more importantly, reduce the prevalence of growth retardation. That, I think, would be and that's where we have gone. The second thing, and this is a plea to all of us here, is to please screen for thalassemia. The obstetrician does not screen for thalassemia. It is such a simple thing, but they don't screen. You don't even need brains for it. All you need to do is look at the CBC of a mother and a father, of a parent that comes to you, and you are going to say that they are probably carriers and they need further testing at all. And why I'm saying that is because, unfortunately, the thalassemic baby does not come to the obstetrician. He comes to us at 2, 3, 4 years of age, and you all have perhaps nothing to do with the further management of thalassemia, but perhaps you all are responsible. And I've been shouting from rooftops that unless we get obstetricians involved in the management of thalassemia and prevention, we are not going to get anywhere. IEMs, I'm going to touch on this just because IEMs in days gone by, Madam will remember and tell us that all newborns who died with obstetricians died of neonatal sepsis. I don't remember with B.N. Purandre. I'm talking of the time of Dr. B.N. Purandre, V.N. Purandre, Madam Motasha, and the babies who died, and we were residents in those days, said, maybe Marigiu, probably sepsis diagnosis api devanu. So, but we know now that many of them may have been IEM, and of course, the next thing is the importance of genetics. Now, this is a picture I have taken. When I joined Wadia in 68 December with my own camera. This is a baby that I was looking after at Navroji Wadia Maternity Hospital. This was the type of care that we were giving, hot boxes, all right, like samosa boxes, hot boxes. But we had a nurse called Sister Epan. Sister Epan drove the life out of me. She was the person who was responsible for me getting any discipline in my life, if there was. Because if I entered that ward without washing my hands, those days we were not masking so much, or being very careful, she would take a ruler and hit me on my finger. Go wash your hands. She was in charge, I was the RMO, and she would actually beat me. Get out from here. Go wash your hands and come. And things like that. So, you know what I'm trying to say? We had this kind of hot boxes. We had this kind of hot boxes where you can look where how the oxygen is coming in from there. And then, like all of us did, we graduated into the American way of getting these Armstrong incubators. All of us, I think, I hope none of us are using these Armstrong incubators. We thought that we put babies into incubators. Incubators would do the rest of the work. Next morning we saw the baby was dead, right? So incubators did not help babies survive, right? And then we didn't know, actually. We didn't know in those days. I'm just going back and trying to come up to from 1968 December till 2 weeks ago, 3 weeks ago. There is somebody talking on MRI, so I have not gone much into details. But there is, we didn't know a word about intensive care. 69, 68. And my boss used to come and tell me, Rashid Dikra, because he had no children, we had the same name, he used to call me Rashid Dikra. You keep a good watch on this child, huh? Keep a very good watch on this child. My concept of keeping a watch on the child was keeping a watch on the child. I really didn't know what keeping a watch on the child was. This is what I thought keeping a watch on the child was, and I took pictures of this to show the boss. So this is what I have done, kept a watch on the child. Yeah, and then you would come and say, baby needs to be put on a ventilator, put a baby on a monitor. So baby, kabhi khabar hi nathi ki how to put babies on monitor, what to do on monitor. No idea of monitors, how to monitor and how to put babies on ventilator. Oh, put a baby on a monitor. This was our concept of putting a baby on a monitor. What I'm trying to say is, this was from where we graduated into slowly coming to where we are now. And then, of course, this is the NICU that I worked with for many years at Surya Hospital with my younger colleague, Dr. Javed, here. And you know him, Dr. Javed. He's an excellent neonatologist, of course, now abroad. So then we began to realize that there's something called fetal smallness. Yes? And then as we grew into our own, as I grew up into a little bit, I began to look at this fetal smallness into small but healthy, and we coined our own terms, benign. They're small but healthy, but benign. They're not sick. And they're small but unhealthy. They're sick. They're small, malignant IUGR. They're malignant small babies. And therefore, when you looked at them, I'm again trying to say that IUGR has not reduced. The prevalence maybe it has reduced a bit, but not as much as I would like to have said that over the last 50 years, we brought down the prevalence of IUGR to what extent. And of course, then we had the preterm low birth weight, and we all know that the problems that the preterm low birth weight are going to be presenting, some of the problems are different, completely different from that of the growth retarded fetus, right? We have got two separate small babies, preterm, and small babies who are growth retarded and growth restricted, or whatever you want to say. And therefore, as time went by, we began to understand, after doing sonography, that when we got sonography and Doppler in our hands, we began to see that doing Doppler studies was the way, in fact, to find out which were sick babies and which were not the sick babies. So we started doing Dopplers along with our obstetricians, and we had Dr. Amar Bide in those days. Some of us would remember Dr. Amar Bide. Yeah. And then we started doing umbilical artery, uterine artery, fetal middle cerebral artery. This is a very important thing, the fetal middle cerebral artery that we started looking at, and the ductus venosus. And just to show you that the placental circulation, and we all know this, is a low pressure circulation. Am I right? The placental circulation is a low pressure circulation. And when you look at the systolic and the diastolic wave, what we call the S/D ratio, you can see that the S/D ratio here, you can really see that how nice the S/D ratio is. The S/D ratio is about 1/3. The diastolic flow has to remain right through for the fetus to grow. Right? This is a normal umbilical artery flow. I'm looking at umbilical arteries. I'm not going into uterine. I'm not going into the details of the MCA because there's time restriction. But then you had mothers who had hypertension, diabetes, what have you, malnutrition, and then you can see now this. You can see this, and then you can see this. You can see the S by D ratio here, the systolic to diastolic ratio, and now you see, you see the normal umbilical artery flow, and now you see the systolic to diastolic flow. The diastolic flow has begun to reduce, right? And when you have low diastolic flows, these fetuses now stop growing. At this point of time, KEM Hospital, Dr. Mota Shah, and many of the other people started doing what is called the FLASP trial. I'm sure some of the obstetricians are aware of this, of the FLASP trial and the CLASP trial. And the idea was that if the placental circulation had a vasculopathy going on, like the coronary circulation or cerebral circulation, try giving aspirin. And it turned out such a big hit that the use of aspirin was so effective. That's when we all started using aspirin in the late 70s or 80s after we had Doppler flows. And then you come to an even greater situation when you had umbilical artery flows which were absent. Now you see that here you had some amount of flow, diastolic flow, yeah, and the fetus was given aspirin, mother was given, and then you had absent diastolic flow. Now this was trouble. If you had absent diastolic flow, and this was a forerunner to a fetus who would die, get into an IUFD, and therefore, if in our time, if the fetus was more than 30 or 32 weeks, we did a C-section and gave steroids to the mother and removed the baby. I think you guys do it much earlier now. 27 weeks, 28 weeks, yalla, 26 weeks, wala, yalla. 24 weeks, wala, I heard last. That 24 and 25 weeks, wala, with bad Doppler flows. Because you don't want the next step to happen, which is a reverse diastolic flow. When you have a reverse diastolic flow, it is jana gana mana illa. You lost the fetus, there's an IUFT. So, as we went by and we began to look at fetuses, clinically looked at them as being small, looked at them as being premature, knowing what their problem was, started doing sonographies on them, and we started doing Dopplers. I'm taking you through the story of 50 years, and we started doing stories. And this is just a word to show about the FLASP trial, that it significantly reduced eclampsia, IUGR, and preterm complications of IUGR, but really did not reduce the national level. You can't keep on giving aspirin, irrespectively, because Dopplers are not all available for the whatever number of million babies that are born in our country. Okay. What else did we do, and what else were we able to effectively do, which you people, I'm sure, do not see? We saw sepsis. We saw sepsis, which you still see, but you don't see clinical sepsis. We saw clinical sepsis. And I remember taking a talk many years ago somewhere in Aurangabad, and one of my postgraduate students there who had trained with me and came and said, "Sir, when I have a child who has got sepsis in my lab, and I see a fly coming and sitting on the umbilical cord, I know he has got anaerobic sepsis." And I say, "How do you do that?" He says, "Because remember, anaerobes produce indole and scatole, and they have a particular smell, and the fly comes for that. And when I have indole and scatole, I add metrogel to my form of therapy." So these were all things that we learned as we went by. Maybe it's something for you guys to take home. Okay? Tetanus. You guys see tetanus? Anyone here has seen tetanus? Neonatal tetanus? My God, the amount of neonatal tetanus we saw, it was unbelievable. Congenital syphilis, anybody seen Warburger's side? When I take x-rays and I show the Warburger's side, nobody knows what Warburger's side is. Rubella syndrome, gone. Infections, gone. Sepsis, gone. Tetanus, gone. Syphilis, gone. Rubella, gone. You've got very clever now in managing your RDS. HIV, and I'm not going to be talking about this. I hope sometime Dr. Vijay Yevle gives us an opportunity to talk about infections, in which I could tell you about how we got into the HIV business and how we were able to give antenatal ART, antiretroviral therapy, and prevent mother-to-child transmission. In fact, it was a huge thing, and it was then christened as the Wadia model. And indeed, eye drops. That was the tetanus that we saw. How much? Because babies that were born from the umbilical cord, they put cow dung. You know that? I think it's still been cow dung on the umbilical cord for healing. And cow dung, as you know, is dung, and it contains the tetanus spores. And this is the amount of tetanus that we saw. Unbelievable, 100% fatality. And then we saw small babies, and then we saw bloated babies. And the bloated babies we saw was hydropic babies. And the hydropic babies that we saw were all immune. And the immune babies were all that we saw were Rh disease. And that time, we had grand multiples. Snehal, you didn't have one baby or two babies. Our mothers who came to Wadia and delivered had 6, 7, 8 babies, 10 babies, 12 babies, you know. And each time, if they were Rh negative, they were sensitized. And each fetus, therefore, had a greater risk of getting eye drops. You follow that? So much of eye drops, which again, none of you, I'm sure, get a chance to see. So what did we start to do? Since we were doing studies along with, again, I'm not going into detail because there's so much detail about it. Chandar Lulla, who's the handsome young man right in front there, he went and trained with Charles Roddick in UK or wherever he went. And he came back and he taught us to do percutaneous umbilical blood sampling. And you can see him there. That's our whole team from the ICMR, our IIH ICMR team, doing a percutaneous umbilical blood sampling. You can see all these mothers were Rh negative. Yes, all the fetuses, when we got the blood, were positive, Rh positive, and we started giving them Rh negative blood, irradiated, when we could get them irradiated, and to bring the hemat. You can see this picture down here, how pale the blood is when we are aspirating the blood with the pubs, and then injecting the blood there. And then we, of course, published this article, which was the first article that came in, where we studied about 27 fetuses who had received about 65 intrauterine transfusions and their survival rates and how well they did postnatally. Then, of course, as I said, you come to 6 newborns. The obstetrician who saw a sick newborn said it was sepsis. But then we began to realize that not all of these who died suddenly were sepsis, but many of them that looked like sepsis, in fact, had inborn errors of metabolism. Now, I think it is too much for you as an obstetrician to think about urea cycle disorder, organic acid, amino acid. Please refer quickly to our geneticists here if you have a sick baby, and even if you think it is sepsis, because sepsis may precipitate inborn error of metabolism. And therefore, we all know this, and I plead that every baby who goes home from the nursery should have a heel prick test, and I call it the healing touch, where you are able to just do a heel prick, do a dry blood spot, and able to pick up hypothyroidism. Mind you, you don't want to pick up hypothyroidism at this clinical stage, yes, because this child is already mentally gone. Nor do you want to pick up a congenital adrenal hyperplasia, because this is so common, and so much missed. CAH, I just had a baby about 3-4 weeks ago, a female, brought up, reared as a male. And you can see if you have got a female with CAH, they have ambiguous genitalia and they're often reared up as males. So we started even looking at that by doing dried blood spot testing. Males, it's a different matter altogether. And then, of course, galactosemia. And then, of course, G6PD, male children with certain communities, particularly Zoroastrian and things like that, and biotinidase deficiency. This is important. This is something that we would send to Parag or to Snehal and tell, look, please do genetic testing for biotinidase or G6PD and things like that, right? So there are indeed lots of benefits by doing screening. Most important is early intervention. I can't stop with the talk without saying about thalassemia, because this is really the major problem that we are facing. This is the single most common gene disorder. We are talking about genetics in perinatology. This is the disorder that obstetricians should be aiming to prevent. And why should we be aiming to prevent it is because, you see, demographically, 4% of our patients are carriers in thalassemia. So these obstetricians go and screen everybody for VDRL, they screen everybody for HIV, but they don't screen for thalassemia. Yeah? And then the babies are born with thalassemia. 10,000 babies are born every year, 1 an hour. So when 2 of our talks are over, 1 thalassemic baby is born. We know it is autosomal recessive inheritance. And see how simple it is. Any obstetrician, any one of us who looks at a blood count, please don't only look at the hemoglobin, but look at the RBC. Please look at the RBC. This mother has a hemoglobin of 10 or 9, but if you see her RBC count is 5 million. So with a hemoglobin of 9, you got no bloody business because it's blood, to have an RBC count of 5 million. And yet, when you look at the MCV and the MCH, you see how low they are. They are below the normal 85 and 35 that you're supposed to be. So you have a microcytic hypochromic anemia with a low hemoglobin and a high RBC count. This is thalassemia staring on its face. But not a single obstetrician will pick this up antenatally. And therefore, they will have 2 thalassemics getting married and producing a thalassemia major, which we don't want to happen. But this country got rid of it by doing antenatal screening. And I want to say that Ulhasnagar is one center that I have been visiting and who have also got rid of thalassemia. For the obstetricians here, we are now into the age where you can do CVS and CVB and look for either in the CVS or in the amnio and look for the genetic mutation. And the common mutations that we see are IVS1115 and these mutations. But some are also silent mutations. And I don't know if you are doing in this institute, are we doing PGDs here for thalassemia? Not yet. Are you? If not, why not? Here, PGDs are being done for thalassemia. So, we reimplantation genetic diagnosis. So, I'm going to quickly pass through that. As I said, when I was young, we diagnosed all these fancy genetic disorders very simply, just by doing urine tests and things like that. In today's day and age, Snehal does all forms of genetic testing and molecular diagnosis to make a diagnosis. The second thing I want to say, besides thalassemia, is for goodness sake, no Downs should be born. No thalassemic should be born, and no Downs should be born. And we all know, you all know, the obstetricians better than anybody else, that there's first trimester, second trimester training. But I just want to give the last line for us to read, that there's something called NIPS, on non-invasive prenatal screening. In 10 years ago, when I was still in the institute, we would say fetal cells in maternal circulation. Now you're looking at fetal DNA in maternal circulation. And of course, we did ultrasounds in a large number of mothers at Wadia maternity. This is a study of 36,000 mothers that we ultrasounded and found 65 kidney disorders. I'll end now because I think somebody is going to be talking on MRIs.
Yes, so 5 minutes. Yeah.
Yes, time also. And I'm going to stop now because, as I said, it is from 1969 till 3 weeks ago. I'll just run through this, Nehal, that this is the fetal MRI that we recently did at Nanavati Hospital, showing ventriculomegaly, agenesis of corpus callosum, dandy walker, occipital encephalocele, and whatever. So we have now come to the stage where we are able to do this, and just for our next generation, the smart next generation sequencing geneticists here, and I call them next generation students, and for my next generation students, for goodness sake, it's nice to know CRISPR, it's nice to know big things, but please don't forget being a clinician. Please don't forget, don't let the clinician rest in peace. So when you see, As I always teach, Parag, do you remember? I taught that if you see a bird on the tree, it's a crow and not a golden eagle. It's a crow and not a golden. Think of common things first. And indeed, I put this slide for myself, just to get myself back into a proper state of this. And I don't begin to think that I'm some big shot from Panvel or something very grand. To keep a proper perspective of yourself, each one of us must have a dog that completely adores us and a cat that completely ignores us. Thank you very much. This is the 50 years or more, right till 3 weeks ago, that I was able to get my hands on. Thank you so much.
Thank you so much, sir. And we wanted to have this overview actually because how far we have come, but how still we are far from achieving our goals in thalassemia. There's one meeting today on fetal growth restriction going on with obstetricians, and there's so much genetics in fetal growth restriction also which needs to be addressed. So thank you, sir, for an excellent overview. Many people have joined on YouTube Live. We welcome them for today's meeting also. Gauri, if you can felicitate. So we want to felicitate you. Biyani, sir.
Hello.
If you can.
I would request Dr. Biyani to please felicitate Merchant, sir.
So actually, it's vice versa, felicitating us by calling you and seniors like, hearing seniors like you. Till she prepares for a slide display, we know Madam Purandare Madam, but many students are here. She's the pioneer of cytogenetics, Mumbai, Maharashtra. She's taken that field so precisely well ahead. She now heads Genome Center for Genetics, but she has been attached to so many institutes and has many awards, books to her credit in Marathi and English also. But she is more known for her preciseness. Her colleague is and student is here, Vishalakshi, who now looks for more of technical work. But Madam will guide us on chromosomal abnormalities, what is the place currently and how far we have come, where we should know updates in chromosomal abnormalities as such, where we have gone far ahead from karyotype. I'll just display her CV, Madam's. So Madam has been a teacher to many students. She has many book chapters, books. She has been the founder member and ex-president of Indian Society of Prenatal Diagnosis and Therapy, SPAT. I welcome Madam to give overview, and I specially called her for today to share both of these stalwarts to share their experience over years, what they have seen, the change, how we are going in genomics.
Thank you, Snehal.
तुम्हाला लेझर पॉइंटर पाहिजे असेल नाही फक्त हे असं केलं ना हे पुढे की होणार
Okay, good morning to all. Thank you very much for being in, I would say, good number, though it's going on live, because that is the facility available today. But it is so much of learning process for us also, knowing about the newer developments, that I don't miss any chance in attending lecture live. coming from horse's mouth. I think, Dr. Rashid, I must thank you. When I started, you took me back the memory lane. 50 years, you said, and 50 years of my practice, where genetics, they were saying, what is the need? There were two pediatricians I distinctly remember when I went, whose name I will not take. We do not require to see chromosomes to see whether it is Down syndrome or not. And exactly opposite, when we started first, I think Dr. Rashid, you were the first one to give your Down syndrome case was us to do karyotyping. Thank you very much for that, for understanding. Now the thing is that having, you have, yes. Oh, very good. See, your memory is much stronger than mine. I just remember Dr. Rashid, but not the patient. And also, a few years later, neurosurgeon Dr. Biani is there. He came to the clinic and I said, neurosurgeon interested in genetics? Because it was not at all expected, because the response was so poor. Every time it was like, if you do not treat a disease, what is the point in doing the investigations? So from there on, and then we had to do glassware washing ourselves, there were no disposables. So all the difficulties after going through, we have come up now with the availability of technology, microscopes, cutting chromosomes, looking under the microscope, taking photographs, going to the studios and getting them developed and printed. Because if they took even a small fragment of a cell and take as a chromosome, our reports would go wrong. I had an opportunity to take my training in genetics first 1 month at ICMR, and then later on I went abroad because I was not having enough facility. So after in the country to learn, and after 15 years of being in anatomy, I thought that now it is the time that I have to go. I want to learn genetics because of embryology and teratology, what I used to teach students. There I met all these stalwarts in the field, no doubt about it, and they were surprised, why am I learning genetics now? Because if there is no facility of understanding or no facility of having it in the institute. I went along all the institutes, I went everywhere, but everywhere they said, our country doesn't require genetics because we have got other major problems to face. Of all things, you can see in the center is Professor Victor McCusick, Dr. Victor McCusick. When I told him that I'm coming back to India, he said, he was surprised, but he said that nobody goes back after 3 years of training in US, but I said, I want to give this to my country. And he autographed his online Mendelian inheritance in man and say, you will be more experienced because of the practice of consanguinity, because of the lot of ethnicity, all the changes which you see, and the consanguineous marriages. And then I started. Now the word chromosome is one of the most interesting fields, which reminds me of the biology of major influences, which I see now in obstetrics, gynec, fetal medicine, pediatrics, and oncology. Oncology has got the maximum number of tests available now. And probably after OBGYN, fetal medicine, or even more than that, we need it in oncology, but that is not the subject today. After looking at the chromosomes for 50 years, as I said, rightly termed as the golden era, I regard them as my friends. And for me, I'm very proud to say, from cadaveric dissection, I have come to genomic dissection. Now, molecular biology began to have its application in genetic medicine, and late 70s, demise of human cytogenetics was almost like, forced on us that yes, cytogenetics is no more required. But now cytogenetics has adopted molecular techniques, and we are still studying human chromosomes, and clinicians and patients do benefit from it. So the talk is about prenatal and postnatal investigations of chromosomal abnormalities, current update. Common indications for pre and post chromosomal analysis, we'll just go over it. Now prenatal diagnosis, we know from maternal age screening, maternal serum screening, ultrasound marker, NIPS, and pregnancy wastage products of conception to find out whether it is a genetic or a chromosomal factor which is responsible for this. In postnatal, and for all these prenatal today, we have got all screening tests available. So mostly it is not only AMA people stop at, but they say, let's do screening tests. If it is high risk or if there is no family history, then one can skip the test, invasive test, prenatal test, and then go ahead and follow up with further sonographies. In postnatal indications at birth and pediatric group, mainly ambiguous genitalia, dysmorphic face, multiple congenital malformations, And also Mendelian chromosomal disorders, DiGeorge syndrome, Fragile X, Prader-Willi, Angelman. I think that is better than the screen. Then tests to identify the tests which are available to us are routine karyotype. Of course, it is required for numerical and structural anomalies, and resolution is given there up to 5 MB. Fish in known chromosomal conditions, locus resolution is 190. Microarray for complex congenital malformations and developmental delay. Now, fish, you have to know a specific location where you are going to look at. So you know that what is the syndrome. Say, even if you say Down syndrome, there will be a probe for the trisomy 21. So fish is used for that, rapid screening. Microarray for complex congenital malformation, developmental delay. NIPA is non-invasive prenatal screening based on fetal DNA, circulating cell-free fetal DNA from maternal plasma to rapidly screen autosomal and sex chromosomal abnormalities. In Western countries, even for some structural or single gene disorders, NIPS is available. Of course, now, even for routine karyotype, it's very important that every test you offer, you give pre-test counseling about the test and post-test counseling, because many times patient is referred by an obstetrician, do karyotyping. When karyotype, patient doesn't know why, and when they ask us, is there any treatment? And then we tell them it is not a treatment, but management is important. Now, if you look at the types of chromosomal abnormalities are all mentioned here. Left-hand side top is the common karyotype. You can have aneuploidies, or you can have like less monosomies also, or trisomies. Then, of course, there is a group, entire group is added, so it can be triploidy, tetraploidy. So instead of 46, one more set is added. About the numerical abnormalities, all are mentioned here, deletion, duplication, and depending on the gene involved on those chromosomes will be the clinical features, and then the recurrence risk estimated after doing parent studies. Marker chromosome, earlier we used to do whole chromosome paint until microarray came, and then each chromosome was painted in a different color. If you see a small marker, you wouldn't know what is the clinical implication of that, whether it is just a segment like from different chromosomes, some portions come and get stuck and form a marker, or it is the pathological marker. But now again, microarray has come to our rescue. Then autosomal imbalances involving the effects, we all know that dysmorphism, mental retardation, internal organ syndrome, it can be syndromic or non-syndromic. So whenever you see a baby with congenital malformation, even if clinically it is not well-defined syndrome, you have to rule out whether it is a chromosomal. If that step is, we have finished, then you can go to the next line of treatment. Most important thing in sex chromosomal abnormalities, imbalances depend on active X imbalances, and have limited phenotype effects or on the brain, because you may have a Klinefelter who is also having a mental subnormality, or Klinefelter can be, we have got professionals with Klinefelter, we have got babies who are Klinefelter but having mental subnormality, but it is mainly the reproductive system which is going to get affected. Then coming to the, why am I showing these Fragile X? Again, those obstetricians who are here, whenever there is a AMH or premature ovarian failure suspected, which is not suspected until a lot of investigations are done, including the follicular study in that and other hormonal levels. But important is that if you find such a lady who has got either irregular periods and AMH is low, she needs to be screened for Fragile X. Because if she is a Fragile X carrier, chances that she will have a male child. So you do IVF, you do whatever, but you have not found out the cause of her, because we have women who can go up to 40, as you can see in left-hand side figure. There are two males, and though it is mainly, most of the times it is in males, even females can get it. So she had one normal son who came to us for marriage counseling, and 3 siblings who were having Fragile X. Fragile X means they had mental subnormality, and we just did a test looking at the features, which you can see very clearly in the photographs. And then she said, how can it be when I have got one normal child, that all 3 you are labeling Fragile X? We wanted to do her carrier status, and she was a carrier. So they can have premature menopause. So in history, we also ask at what age mother has had menopause. So one important investigation we can miss, so I thought this is a group where I can mention that. She almost collapsed when we told her that you are a carrier. But we had to tell then how did it come, she wanted to know. Then coming to the next slide is fetal tissue sampling. You know the indications, you are aware of the indications, and then what is most important for a laboratory is to receive right sample at right time and a right container. Now, these are the ones which I've given extensively about the prenatal, because that is the one which is decision making, continuation or termination of pregnancies depending on the results. If it is abnormal, patients mostly go in for termination. So the sample collection for amniotic fluid or chorionic villi in a specified container, and moreover, it is never to be frozen. Otherwise, sometimes sample is collected frozen, cells are not going to work in the laboratory. So it should be transport at room temperature, and then if at all you have to keep it overnight, then it should be in the other compartment, 4 to 8 degrees compartment of the refrigerator. Now, in order to avoid maternal contamination, because sometimes you can get mixed line, normal or abnormal, especially this is very common in chorionovillous sampling, because of the development of the placenta and fetus, both may have a different kind of karyotype. So if it is uncommon, when we get a result and we see uncommon trisomy, say trisomy 9, trisomy whatever, then we say, no, we need to confirm it that there is no placental mosaicism, and next level of test is asked for, that to confirm no irreversible action to be taken. I keep repeating that no irreversible action to be taken. Then procedure for genetic counseling. I said that, okay, and in that slide I've also mentioned, I think, about the samples. I talked about prenatal tissues, but peripheral blood, again, because it is not as stable as tests done for DNA, which is collected in EDTA or specified tubes in for NIPS. But for blood, like you require 2 ml, because if the culture, the blood comes late, or if it is not collected properly, culture is not going to grow. Like DNA can be extracted from any tissue, but for karyotyping, you require a good sample, which is, I mean, good means the sample blood is always going to be good, but the way it is transported is very, very important. And after culture failure, blood has to take again. If you are storing DNA, you can store it. I think, I'm sure Parag will say, lifetime, no tension. So we say holidays. People who are doing in the DNA lab, they can take holidays. We can't afford to take, because it has to be harvested on a particular day. Procedure of genetic counseling is very important. I think anybody who is collecting a sample, at least basic knowledge should be given, that reviewing clinical, obstetric and family medical history, if they come to us, of course we do that. Offer tests, because patients say, our doctor has said karyotyping, we are not going to pay you any counseling. I said, we don't want money, but we will explain to you how the test goes. Then, of course, offer tests, we discuss, explain possible outcome, evaluation methods and the tissues, and then informed written consent for all the patients we take. Now, actual testing, post-test, it comes in outcomes. So when we give the reports, what is the outcome? Translocation, VOS, carrier identification, then re-evaluation of data, sometimes it is required. I think just now Parag, we discussed one case where he himself said we had sent him one patient who had done tests with retinitis pigmentosa. He said we need to re-evaluate that data. So you have to re-evaluate the data. No need to rush through giving the report if your consultant geneticist is in doubt of the results which are given. Now, re-evaluation, potential need for parental samples. We may require additional testing, whether parents are carrier or not. Review findings, pregnancy options, paternal and family members, sometimes especially in hearing deficiency. 100 genes are there in gene panel for hearing deficiency. And if you just, like if you have a couple, like we get them for marriage counseling, if their couple is not sharing the common gene, most are autosomal recessive, non-syndromic hearing loss. Of course, syndromic, you will always have the syndrome and the relevant test. But in that case, if they are not the carriers, then they are not going to get a child with hearing deficiency. So we require sometimes to find out where the gene has come from, and then we require parental testing. Then available literature referrals, even many times I tell to the patient that yes, this is something new. I would like to consult another consultant, or I would like to go through the references before I give my final action. Of course, reading results is another important. Snehal, last time you gave a talk on that seminar where liver diseases we did. I never thought anybody would start the talk with how to read the results. I think it was so important, because we know about the pathological tests, but genetic tests we do not know. So also you have to understand how the reports are interpreted and how to read it. And if not, everybody, now many centers, we are one phone call away. So you can always ask before you commit anything. So any chromosomal abnormalities, which are mentioned on the left-hand side, in normal karyotype, you may not require anything. But unless there is previous family history, and another important thing in family history is family history needs to be updated every year. Because if you are going to come next time, then we will have some additional family members born who have got a genetic disorder, and then you will totally miss out on that. Another is CFDNA. We call it CFFDNA. NIPS we talked about. It's a very important screening test, especially for aneuploidies. But now this lady, 20.3 weeks, echogenic cardiac focus, NIPT high risk for trisomy 13. She came for the NIPS test and there was also monosomy of 5. Now such kind of abnormalities, so we know this is cell-free fetal DNA, like Dr. Rashid also mentioned just now. So echogenic cardiac focus, I mean not for this anomaly, but monosomy did not fit with any of these. And even if you get some such kind, not of a common syndrome, possibility that it has come from a malignant tissue. So as mentioned, malignant neoplasia, though relatively rare in pregnant women, occurs in 1,000 cases and accounts for about 15% NIPT false positive. So we did that. In the evening, she went to her doctor, and then her routine blood was again checked, and she was a case of AML. Unfortunately, it was so fulminating that in 2 months' time, she had to do termination, and she also lost her life. So it's very important in interpreting the results. Now coming to most common chromosomal aneuploidies, we know that 13, 18, 21, etc. But we'll just only talk about Down syndrome. Now frequency is 1 in 700 reported in US, but we also see, like again Dr. Rashid mentioned, we should not have a Down syndrome baby born. Per month I must be signing, in spite of all screening tests, not less than 20 to 25 Down syndrome born babies. Now what is important in that, doing the karyotype of the affected, you will see the last is written 21 translocation and 121 already there. But if parent is a carrier of translocation, because we have to do to find out recurrence risk, because if parent is not a carrier, 1% risk. If parent is that DG group or any other carrier, it is maybe 8 to 14%. But if parent is a carrier of 21 translocation, all their babies are going to be Down syndrome. So you cannot use the gametes. Last week we had 2 patients, first Downs born, saying that we have a lot of non-invasive tests, there is no need to do your karyotyping. Couple was told. There were 21 translocation in the father, and then the second baby also was Down syndrome. So I think we are to be blamed for not giving them information. Pediatric surgical conditions also we require a lot of screening nowadays, because again here which tissue, which test is important. Now in Pallister-Killian syndrome, now diaphragmatic hernia, we know that it can be because of chromosomal or it can be many other disorder, many other genetic mutations. But in this particular syndrome, Pallister-Killian, we have to, like in these cases, tissue is important, it grows only in fibroblast cultures. So if you do only routine, you do in a rush because you have to take it for surgery, cord blood, or a newborn baby, you do cord blood, you are not going to get this tetrasomy of 12, what we saw. So which tissue to use? So history, providing us the history is very important, why you want to do the test, if it is going to be for surgery. Also in this surgical condition, so in this particular patient, like we had done amniotic fluid, and you will get the report, whatever is, but if you do cord blood, you are going to miss it. Then again, another condition commonly seen on ultrasound, exomphalus and gastroschiasis. Clinically, you all know because of ultrasound how to differentiate between the two. But exomphalus is mainly associated with trisomy 18 or 21. So more than recurrence risk, with continuing this pregnancy can be high prematurity, mortality, and of course child is going to be handicapped because of this chromosomal abnormality. In gastroschiasis, because defect has no sac or membrane as opposed to this, it can be autosomal recessive. But if you find that there is no chromosome involved, surgical correction is possible. So this is very important to identify and differentiate between the two. Sometimes it is missed to distinguish on ultrasound omphalical and gastrocysts. In gastroschiasis, whenever you are doing a pediatric surgery, it's always better to have at post-birth. Of course, we are still not doing any intrauterine surgeries. But it is important to have the time and mode of delivery is to be decided. Because then early, or you can just get a hydrohospitalis and it could be still 45 XO. It may not be necessarily always 45 XO, but you will have all these kinds of chromosomal rearrangement mentioned. In a newborn, if you get, you see cubitus valgus little bit near puberty, but earlier you can have hydros baby and born, and you want to find out, you are going to salvage for whatever the best conditions you have to counsel that time only what is going to be her future, depending on the position of the loss of the chromosomal material. Like it could be ring, it could be deletion, because either they can menstruate, secondary amenorrhea, infertility. So IVF also in pre-implantation genetic diagnosis you are planning, and even if the woman is normal, fragile X and female karyotype is extremely important. Then isodicentric Y, this is something new we have been seeing over the new in the sense seeing in the practice. Here it is very difficult. Now in prenatal diagnosis, if you are going to look at the chromosomes and you find sex chromosomal abnormality, you cannot declare it to the patient as per the law. Then you have to discuss, take into confidence your referring physician and have a look at the external genitalia. Because everybody is shown screen today, so patient comes to know what it is. So you have to be very careful. So we tell them to look at the external genitalia. Now this particular case is bad obstetric history, but third pregnancy, NIPT high risk for 18. Amniokaryotype plus which 20 cells were examined, and the sex chromosome, they are dicentric Y. That means 2 Ys were there. But what will happen? Now, we have had patients who didn't want to terminate when they got to know through their obstetrician that the fetal sex is male. So we have to be very careful. But what will be the outcome? If they terminate, it will be the fetus otherwise would have been Turner. So it will look more or less, unless you see something at birth Turner, then they will say it was a normal female. They can be born with ambiguous genitalia. It can look like a normal female also. So you tell them in isodicentric Y, and then outcome, they will come and catch you that baby was looking normal. Why did you say it was abnormal? So you have to take obstetrician in confidence. Prenatal sex chromosomal, sorry. Then coming to the importance of microarray results, this is excellent slide I would say that what we got. Now increased NT is one of the most, we have got now 11 to 13 week scan where there increased nuchal translucency, or it is also called as NT scan along with dual marker, etc. Now there are 150 syndromes associated with increased NT. So if the chromosomal report, prenatal karyotype report comes normal, every sample of prenatal diagnosis, a split sample must be saved for DNA. Because DNA storage, because it costs hardly 1,000 rupees just to store. So along the pregnancy as it is going, you find any other anomaly, especially achondroplasia, because which may appear at 25 weeks or 26, the short bones may not be appreciable earlier. So in this case, like they had first nuchal translucency, they terminated because there was inversion of Y chromosome, which was not told to them because father also had same. Next pregnancy also, and it turned out to be microarray showed that's indicating trisomy for the genes mentioned here, and that is Charcot-Marie-Tooth. So all increase NT, if karyotype is normal, further evaluation must be done. Now lawyers are also getting clever, those who are into practice. I've been invited to talk to lawyers to tell them about genetics and how the genetic conditions come, then how it can be handled. In this particular case, we had done prenatal diagnosis. It was only hypoplastic nasal bone. Fish karyotype was normal. There was addition of chromosome and parental karyotype. A big chunk you can see addition of chromosome 9. Before microarray, we would have said, like previously without microarray, we would have missed. In this also, in previously, the court said she had crossed the legal limit of termination. So court said now you have to require a permission. Then we told them it's already extra segment. Now she had gone up to 25 weeks, and then it was like they wanted to know what that extra segment contains. So we did microarray, and we have told them what are the, as it is in the cytoband region, trisomy for the region, characteristics of developmental delay, intellectual disability, behavioral problem, and distinctive facial features. Here DNA was not stored, so we have to redo the amniocentesis. All single gene disorders can also be associated with chromosomal abnormalities. In postnatal cases, most common is we see is ambiguous genitalia. Again, sex of सबसे important is birth registration, and as soon as baby is born, क्या हुआ? Nobody can tell. So we have, I think Dr. Rashid has also told something about it. But we'll have to find out their total karyotype, but it is not just the karyotype. Like right hand side, you can see testicular feminization. Gonads are there in the labia. And this is XY. This girl has come little later, but even at birth we get cases like that. And otherwise, now if you say if it is testicular feminization, XY female, we have to guide them for chance. Otherwise, she is going to be normal, beautifully looking female without menstruation. But later on, it can turn into gonadoblastoma. Because for a genetic center, nobody comes twice or again and again. Once we give the report, it is done. Single gene disorder, this was a case of cardiomyopathy. They came for a consultation. She had repeated 3 abortions. So I said, this has got nothing to do with cardiomyopathy. And we did karyotype. So these two can also go together. These are all different microdeletion syndromes. We know we have got FISH probes available. So the previous slide says that even if there is a single gene disorder, you have to do the karyotyping. In conclusion, cytogenetics has evolved from being a research tool to an invaluable collection frontline diagnostic tests. Its ability to view the entire genome of an individual in a single test has given paramount importance in disease diagnosis and clinical management. You all will agree. And advances in tools, techniques have provided higher accuracy, resolution, reproducibility. This is even more desirable in pediatrics and cancer research, and or the neurology neurology. For example, research now, most important is now, they are working on silencing chromosome number 21, the gene. Because if at all you are normally looking Down syndrome baby clinically, and you find that there are chromosomes are normal, you have to do a microarray to find out whether there's a critical region on chromosome 21. And they're trying to silence that gene for chromosome 21. So this work is going on. So I think we should also update ourselves. I thank Apollo Hospital and Snehal for giving such an opportunity, wonderful opportunity I should say, for whatever we are doing in today's current scenario of genetics. Thank you.
I was going to say 5 minutes, madam, but you well finished in time. And thank you for such an excellent overview. Madam has such a huge number of cases and laboratory experience. This was just a glimpse of it. Madam, few questions you said that Vishalakshi would also take up.
Yeah,
so
if we can questions, if at all. Come,
we have questions.
Vishalakshi is very knowledgeable, more than 20 years with us. Totally
yes, madam.
dedicated.
When we phone up, yes.
To the
so a few questions to Vishalakshi and madam, that whether every CVS sample or amniocentesis sample, are you storing DNA, or there are few indications you store the DNA, otherwise you just do a karyotype and keep the cell button?
Do not store DNA for all the specimens. Yes, according to the indication, we do store the DNA. Otherwise, it's a fixed pellet which is stored.
And from the fixed pellet, how many days it is stored, and whether we can take the DNA out of it?
From the fixed pellet, it's difficult to take a DNA. But from the amniotic fluid and from the cultured flask, yes, cultured flask we do keep for 15 to 20 days after the reports are done with, depending on the indication, so we can store the DNA.
So we can take that DNA from that cultured flask. So that is the message which we want to give to obstetricians, pediatricians. That sometimes report of karyotype comes negative. You have an IUD baby, stillbirth baby, you have an abortion, report comes negative, and then we have to do the further investigations. The sample earlier was not sent for DNA storage, so definitely you can get back to the laboratory, talk to them whether they have the sample, because according to accreditation guidelines also they have to store sometimes sample, and we can definitely take out DNA, which we are doing in our practice. So please have continuous communication with the laboratory. That was my purpose to call laboratory people today. And some things where you get difficulty in culturing. What is the least gestational age, like 8, 10, 9 weeks? Abortion that you have been successfully doing karyotypes, and what would you recommend in such early abortions?
If you have early abortions, then as low as even 6 weeks, if we are having a good villus, then we can do a culturing of that. But otherwise, we do microarray for these cases.
So for every, somebody has sent you the sample 6, 7, 8 weeks, you immediately extract the DNA?
No, we don't extract the DNA. We actually separate out the tissue, store a bit of tissue for DNA removal later on. But we first do it for karyotype, because majority of the small gestational cases, we have found that almost 80 to 90% 90% of cases there are chromosomal abnormalities in such cases.
And they have excellent, I mean, Madam and Vishalakshi, they have excellent eye. They have done such a precise diagnosis on such least gestational ages, where we have got sometimes microarray difficulties, but we have got karyotype, their karyotype interpretation, excellent karyotype interpretation.
I want to add something, because microarray has its limitation. Even if microarray report comes normal, now we have got cases because they have a tendency to jump at the higher test, but parental translocation cannot be ruled out, low-grade mosaicism cannot be ruled out. So even if microarray comes normal, we go back and tell them to have parental karyotype done. So that if translocation is there, further pregnancy, at least they will have the background.
In many cases, we need to have dialogue with the laboratory. So please have that dialogue. Samples are stored. You can get sometimes answers in negative cases. You can take the sample and do further processing. So that just I wanted to ask you. Yeah, thank you. Thank you, Vishalakshmi Madam. You can felicitate Madam with...
Yeah, sure.
Nowadays, we are seeing a lot of autistic and autism in the children, basically. So, what more can be done to prevent this problem? And nowadays, you must have read about the controversy regarding injecting stem cells in the autistic children. That was done basically, and then a lot of controversy is there. So, your comment on that?
I think Dr. Parag would be a better person to ask. Parag, you can answer that question, because he's master in this, pediatrician and into molecular.
Yeah, so autism is a complex disease. You have single gene causes, you have chromosomal causes, and you have non-genetic causes. There are other non-genetic causes like congenital infections also can sometimes, maternal diabetes, maternal hypothyroidism. So the diagnostic yield of genetic testing using different technologies for autism is not more than 20-25%, even using the highest technologies possible. Of course, if you have familial history, you have a dysmorphism, you have, in addition to autism, other systemic abnormalities, then there is a higher risk of finding, if there are other birth defects, there is a higher risk of finding a genetic problem. But so basically, autism is not a diagnosis, it is a symptom. We need to find the underlying causes. Genetic testing is very important to know the diagnosis, prognosis, and the treatment management options, and of course prenatal diagnosis.
Yeah, because it's a spectrum disorder. You may have more than 100 genes. Out of that, anyone can be responsible. I want to tell give tip to the audience. Like mostly patients say that tests are very expensive. So I tell them, okay, that's fine, I understand. It's once in lifetime test and generations is going to be the same, so it's going to help. Then I start with their mobile. Do you have a mobile phone? They said, yes, madam, switched off. Husband ka, wife ka, switched off. I said, how much did you pay for your mobile? Everybody has got a smartphone. In a family, 4 members, minimum 60,000, 15,000 का तो मेरे भाई को 6 बच्चे हैं, उसके सबके पास स्मार्टफोन है. And she's earning hardly 20, 25, 30,000. And yes, agreed.
So the first thing we tell autistic patients is that 0 screen time.
So we are saying it for adult autism also. We are not talking to each other, so adult. Yes. So in a summary, autism you have to
come for the tests. If you explain, they are very happy. Yes, we understand.
So to make a precise summary, autism, genetic, non-genetic. In genetic, you will get higher yield of genetic investigation. So first you have to see whether as dysmorphism, family history, any pointers which will you suggest that you go ahead with genetic investigations. If everything is negative, just an autistic child, you watch for it, evolution of dysmorphism, whether to take up genetic testing and then explain parents. And stem cells, of course, that it is a clinical trial. So protocol has to be followed if it is a clinical trial. Otherwise, and clinical trial has to be free. So there are a lot of protocols which are not being followed, which we have read in newspapers, so not useful. Only for blood disorders. That too in communication with the doctors. Thank you, madam. Sir, I request you to felicitate madam. We are going to have session on autism genetics also. So every specialty we want to deal in a different way so that you have specific answers from that specialty. Yeah, thank you, madam.
Ma'am, slightly come this side.
now we welcome Naresh Biyani sir. Sir, your CV is so big. I don't know whether we will be able to read through it, but sir has an excellent case collection of CNS abnormalities dealing right from pregnancy. And I keep telling sir, you need to come and teach us, and I could get him for today's meeting for antenatal presentation of fetal neurological abnormalities. He's an excellent person to deal with such problems. And I request obstetricians that before sending it to geneticist, please take his opinion. He's so excellent in giving those neurological abnormalities overview, and you will experience when we hear him. Sir is attached to many hospitals, Apollo hospitals also. He comes as a neurosurgeon. So your presentation has been, isme hai? Acha, okay. Okay, so I welcome Dr. Naresh Biyani, who's a senior neurosurgeon, pediatric neurosurgeon, and specifically dealing with, sir, spina bifida also. He has a huge experience. Yes, everything in pediatrics, but spina bifida, like occult problems also, he's so excellent at.
Good morning, everybody. Thank you, Dr. Snehal and Apollo Hospital team for organizing this CME. It's mainly for the obstetricians, actually, and it's always a pleasure to stand and talk in front of Merchant sir. He's been a very role model. So what does the fetal medicine team involve, So it consists of an obstetrician, radiologist or sonologist, pediatrician, neonatologist, and since I'm going to teach with the pediatric neurosurgical problems, a pediatric neurosurgeon or pediatric surgeon in a surgical problem, or a urologist in a urological problem. So the question is that whenever there is an abnormal report, at the antenatal scan, so the family has a big dilemma. Okay, there's a perspective of suddenly having a severely damaged and crippled child. Current state of MTP is around 24 weeks gestation, and there are a lot of questions that the family wants to ask, and they don't know what to do that. So mainly the antenatal consultation consists of the prospective parents come to know about the condition, its long-term outcome. Prospective parent and the team, treating team, develop a rapport where a decision for the lifelong consists for the baby and for the family is taken. And they also know that they don't have to run pillar and post once the child is born, They know there is a treatment that is available. In next 30 minutes, what I'm going to run through is ventriculomegaly and hydrocephalus, and cyst in the posterior fossa. These are the two common neurosurgical problems that we see. If time permits, maybe supratental arachnoid cyst or spinal dystrophism, but even these two things, if the points are hammered into it, that's fine. Okay. So what are the investigation tool that we have got is a sonograph. Okay, it's a nice real time, everywhere is available, and non-ionizing radiation. And we can see almost all the abnormality that can be seen, and with the 3D images, it's very nice to see. And then we have specialists who specializes in doing antenatal scan, the fetal medicine expert and the radiologist. That's fine. So what's the definition of ventriculomegaly? When do we call that there's a ventriculomegaly? Ventriculomegaly is the upper limit of the ventricle at the trigone level should be 10 millimeter. Anything above that, mild would be 15 millimeter, moderate would be up to 20 millimeter, and severe would be 20 millimeter, more than 20 millimeters. Okay, frontal horn, temporal horn, occipital horn, we don't call. we have to just look at the trigone level. And the moment we see, as a pediatrician or as an obstetrician, we see the report with the ventriculomegaly, the report, the good sonologist also should mention about the frontal horn, the head circumference, the bipedal diameter, in India, the spine screening has to be done, and also the midline abnormality that is associated, the corpus callosum, Dandy Walker, and all those stuff. If you don't see this report in an ultrasound report, then probably we should call up the sonologist and ask him, the reports. Most of them, they put it in the report. The causes of ventriculomegaly: developmental, destructive, or obstructive. Okay. Developmental would be neural tube defect, agenesis of corpus callosum, Dandy Walker, lissencephaly, and all those stuff. The thing that I'm going to talk is about the treatable causes. What we have got. So this is an entity, just an asymmetrical dilatation of ventriculomegaly, and where a role of fetal MRI is also helpful. Okay. Again, fetal MRI is not essential. It is not available everywhere, but it is helpful in evaluating the where we want further more information. Okay. I'll run through a cases, then you will be able to know that. So now, now you have a child, you have an antenatal scan that shows ventriculomegaly at 30 weeks, the gestation 16 millimeter, and at 34 weeks it is 37 centimeters. And this is what the scan looks like. Okay. So I'm sorry. So this is the dilatation of ventricle. This is the frontal horn also that is dilated. Yeah. There's the frontal horn also that is dilated. Okay. And this is the scan. This is the scan of the report. That is what an obstetrician or a pediatrician would come. So the important point that I want your attention is that the gestational age is 34 weeks. And when we see the bipedal diameter, the head circumference, they are 36 weeks and 37 weeks. So a few of the reports, they come with a percentile, and then there are people who would put it as the weeks also, And that is the telltale evidence, So this child has an hydrocephalus. Suppose the same child, if the bipedal diameter and the head circumference were low, low below 34 weeks gestation, 32 week or 30 weeks, and associated with IUGR, then that is a totally different issue. So you can have a dilated ventricle with other signs. Okay, suppose the same thing was like 32 week or 30 weeks, then there is no role of a neurosurgeon. Then a pediatric neurologist would take over. Dr. Snail would take over, It's something like that, And the report has everything. It is for the obstetrician or the pediatrician to infer from that report. Okay, coming back to the same cases. So now you see this here. It's quite big, at 34 weeks gestation. As a pediatrician, when should we deliver the baby? That's a question, Whether the child would require surgery, what would be the prognosis? These are the three things that the obstetrician wants. And they expect a pediatrician to answer them. And pediatrician also looks at the neurosurgeon and expects the answer, So what would be the prognosis for this child now? Good, bad, not so good? Okay. So now the child is delivered. This is the MRI scan that is done at day 3 of life. Okay. Large ventricle. You can see the periventricular lucency. That means that there's a chronic hydrocephalus. Now this child, this is an aqueductal stenosis, and this is the telltale evidence of the bleed. Now this child was all well before 30 weeks gestation, and this is slightly delayed, acquired. Okay, this is not a malformed brain. So the prognosis is good. And we can see, this is the SWI images where we can see the residual telltale evidence of the old hemorrhage. So if now the ventricles are appropriately drained, the child has a good prognosis, because the brain, to start with, genetically was normal. Because of the hydrocephalus, the brain was getting compressed. Okay, this was the CSF, and this is a scan after 3 months. We put in a VP shunt, and then the ability of the neonatal brain, the plasticity, the way it can grow back if an appropriate environment is given, is phenomenal. When we talk to the family, and we tell them, there is a abnormality that is there right now, but if given a appropriate treatment, the brain can grow back, They hardly appreciate or would believe also, We'll come to the second case. 32-week gestation and had a large intraventricular bleed. Okay, this is a fetal MRI that was done, and the white thing that you see is all bleed, bright on T1, you know. Okay, this is the bleed. Okay, the child is delivered after the lung maturity is secured, and now this is the scan, you know, dilated ventricle, but on a CT scan you would not see a bleed because the bleed is getting dissolved. And what we do is we put in a reservoir. What I do is a ventricular lavage, and lavage, the first fluid would be like this, and we clean it up to like this. The idea of lavage is to decrease the hemosiderin load so that the risk of hydrocephalus or attended complication decreases. Case number 3. Again, 28-week gestation. This is all 4 ventricles dilated, third ventricle, lateral ventricle, and then there is a posterior fossa cyst, the cerebellum agenesis. Prognosis, Dandy-Walker malformation. Not so good, you know. Then this is what the child is born with. Again, you see the cortical mantle, you know, it's all severely compressed. A lot of people would give off the hope also, you know, why should we treat it, you know. But again, we are not gods. We are there to do our job. You tell everything to the family, and if the family is willing for the treatment, we should not stop that also. Okay. Now this is the follow-up scan after 6 months. We put in a shunt. You see there is nice subdural collection. The brain is started falling down. Okay. We can see the sutural overriding also, you know. So that's a good sign. And then after 12 months, you know, these are the telltale evidence of the antenatal damage that had happened. But you see the brain, everything has grown back. And this is the phenomenal recovery power of the neonatal brain. Another one, 34 weeks gestation, you see there is a dilated ventricle. That's it. And only the occipital horns are dilated. Okay. Now, when we see the fetal biometry, you know, again, bipedal diameter is 35. This is also corresponding to 35. Now, what are we dealing with this? Anybody? Now, the child is born. Now, you see this is a tear-shaped ventricle. Absent corpus callosum. This is a colpocephaly. No need of any surgical treatment at all, you know. As the baby grows, the ventricle size would decrease by itself. So it's a benign condition, nothing to worry. And no surgery is needed as well, you know. 29 weeks gestation, antenatally diagnosed hydrocephalus, the child has IUGR and has ventricular dilatation, you know. And postnatal, this is what we see, you know. So this is a telltale evidence of the CMV or torch infection, you know, the calcification that we see particular. Prognosis is not good. Okay. I'll run through the take-home message at a later date. I'll touch another very important topic where there is a lot of confusion. You know, even at the level of sonologist and the people who do ultrasound, forget about the obstetrician and pediatrician. Okay. Cyst in the posterior fossa. Okay. To understand that, you know, we need to understand the posterior fossa development, you know. So what does the posterior fossa has? There's a midbrain, pons, and the medulla. There's upper cerebellum and lower cerebellum, and then there is a cyst, cisterna magna. So this is a basic thing. Okay, and this is what we see in the axial scans. Okay, the most commonest abnormality in an antenatal scan, when they did a multivariate study, you know, so what was the commonest was posterior fossa anomalies. So this is the burning problem that we should be aware of it, you know. And what are the 4 types of abnormality that we see routinely? Is a mega cisterna magna. Accounts for almost like 40% of it, you know. 45% rather. Dandy-Walker malformation, another 45%. So if you see these 2 things, you know about these things, 90% of your abnormality is covered. Okay. Then there's a pouch of Blake cyst, and then there's a posterior fossa arachnoid cyst. They amount to around 10% of the abnormalities. And how does the posterior fossa look like? This is a fetal MRI where you see the brainstem, you see the vermis, and then there's a cyst that is communicating with the 4th ventricle. Embryologically, what happens is that when we take the cross section, you know, the rhombic leaf arises from the lateral side and they fuse and form the cerebellum and the vermis, and the cavity that remains is the posterior 4th ventricle. And suppose there is an abnormality in getting united by the two lips, that is when the posterior fossa cyst communicates with the fourth ventricle. Okay, and then you see all sorts of abnormality. Why embryology is important? Because we can understand and can prognosticate as well. Okay, and the development, the roof of the rhombic cephalic cyst is already done by around 18 weeks gestation. But we tend to diagnose them at a later date. Okay, these are the Vermean measurements, the fastigial declive line that we follow, that's okay. But Robinson, he is the person who has done a lot of this work. Okay, anybody who has time or who is doing the counseling should read his article. Okay, one of the best. Okay, so what he mentioned was in 2016 actually, is quite recent, is a tegmento-Vermean angle. So this is the tegmentum and this is the Vermean. So normally it is less than 30 degree, 23 degree. That's the normal one. Okay, you see this here, it is more than 23 degree, so it can be a pouch of black cyst. Tegmentum is the brainstem, sir. Brainstem. Brainstem Vermean angle or tegmentum Vermean angle, that's what they call. So when we are dealing with Dandy Walker malformation, we see tegmentum Vermean angle and tegmentum tentorial angle. These are the two things that. This is fetal MRI, but USG also they do it. So next time when you see a Dandy Walker malformation report, pick up a phone, talk to your sonologist and ask him, why he has not mentioned these two angles. They should rather. And that is how we can come to a conclusion. The patient would just come with the report, They don't come with the films or we don't know what is the angle, Okay. So these are the fetal MRI. Fetal MRI is good for representation purpose, but USG also now we get with the nice 3D, 4D ultrasound, similar to an MRI pictures. Okay. So the brainstem Vermean angle, that is the telltale evidence, if something has gone wrong or something is normal. Okay. So this is the angle, Vermean, tegmento-Vermean angle, and this is the article that he published in 2016, quite recent. And this is important, after 20 weeks, less than 5 degree angle, posterior fossa arachnoid cyst, up to 18 degree, it is normal. More than 23, up to 30, means more than 18 and up to 30, it can be a pouch of black cyst. And more than 35 to 40 degrees, Dandy Walker malformation. It makes our life very easy, once we know this thing. Okay. Then he also added brainstem tentorial angle for Dandy Walker. Because in Dandy Walker there are 6 things, and one of the things is the large posterior fossa. When you have a large posterior fossa, this is acute now, it would become like a 90 degree or obtuse, more than 90 degree. Okay, now we come to the abnormalities, So 4 abnormalities we talk. Megacisterna magna, the cisterna magna is normally seen up to 10 millimeter, it is normal, nothing to worry. You have a report that comes, that 9 millimeter cisterna magna, 10 millimeter cisterna magna, nothing to worry. It is a benign, it's a normal entity. And up to 15 also is normal, they don't have anything abnormality at all. It's just a space of water outside the brain, extra-axial. Okay, and the good part of it is that it is a posterior fossa cyst that doesn't communicate with the fourth ventricle. The worm is, the cerebellum, everything is normal. Cyst doesn't communicate. Okay, and the posterior fossa is normal volume. Then comes a pouch of black cyst. We would see that, the pouch of black cyst was seen in some ultrasound and then it disappeared. The radiologist didn't mention that. And the moment there is some abnormality written in the report, the family gets panicked. So why this happens is that there is a roof of the fourth ventricle that has to be formed, and there is the inability of that membrane to rupture. And it protrudes like a cyst. It remains there. By 28 weeks, 30 weeks, it ruptures by itself. So it's a transient phenomena that happens. Okay, and it doesn't have any abnormality with the vermis or in the development of the cerebellum, pouch of black cyst, midline deformity. Okay, and how do we diagnose them? Brainstem Vermean angle. Most of the time, the fenestration it ruptures by itself by around 24 to 26 weeks. Okay, this is a fetal. This is a fetal MRI that again shows that the pouch of plexus. But in pouch of plexus, you would see the posterior fossa is normal, the volume is normal, the vermis is normal, and the tentorium is also normal. And it's a transient condition and no neurological abnormality. Now comes the difficult nut to crack, the Dandy-Walker malformation. So Dandy-Walker malformation consists of 6 pathologies. So when you have all the 6, it is called as Dandy-Walker malformation. If you have any of few of them, then we call as a variant. Very simple. What are the 6 things? 3 are important. Posterior fossa cyst that communicates with the 4th ventricle. There is an associated hydrocephalus. There is a cerebellar and vermian agenesis, hypoplasia. You have a large posterior fossa volume actually. It's a large posterior fossa. Okay, the posterior fossa is big because of the cyst. So that is again, because of cyst, this is the collateral condition. Torcula is away from the foramen magnum. Again, because of the cyst, the torcula is away from the foramen magnum. And the tentorium is more vertical. Again, these 3 things are like corollary. The main important thing is the first 3. Okay, and when they do a sonography, how does that look? So this is the cyst, and this is a choroid plexus. The sonologists are very able to find the choroid plexus, and they can see the choroid plexus that is upturned, and they can easily diagnose that. Okay, and then it comes in various size. It is quite big. It's almost like occupying half of the skull, and this is a moderate one. Okay, on an axial scan, we see that the vermis is absent, and then the cerebellum hypoplasia also. Okay. Somebody who's interested to read, Robinson, he was the person, Ashley Robinson. He presented his work 2014 and then 2016. 2 good articles, Okay. So, how do we diagnose Dandy-Walker malformation? Is that the cyst, that is done. Now this is a posterior fossa arachnoid cyst that is rare. Okay. So the cyst doesn't communicate with the 4th ventricle. You have a normal size cerebellum and vermis. And the displacement of the cystic structure, the brainstem is compressed towards the cerebellum and the vermis is compressed towards the brainstem. We'll run through a few examples that would make life easy. 22-week ultrasound shows megacisterna magna, Cisterna magna is 13 millimeter. Repeat sonography done at 28 weeks shows that there is a vermian hypoplasia but no hydrocephalus, and probably it's a Dandy-Walker variant. And that is when the family comes to you for the counseling, What would you counsel them, Because this is another disease and this is another disease, How are we going to counsel the family? 28 weeks. The people would come to us only when there is an abnormality detected. No, they want to know the prognosis. They want to just know the prognosis, And the worst thing that happens is that when the operation picks up and tells, it's a precious baby, it's a bad obstetric history, and we want to do whatever is possible and all those stuff, So, looking at the report, what do you think is the prognosis for this baby? Good, bad? Good, of course it is. When they come to neurosurgeon, it has to be good. Not like that. So this child was delivered, and this is the scan this is the ultrasound scan actually, child in the womb. Okay, we see there is no vermis. Okay, the posterior fossa is adequate, cerebellum is also seen, and then this is the scan done at day 3. Okay, and what we see is just the cystic structure. We could easily see the vermis, and also you see this is the vermis, and this is the cystic thing. No surgery is needed. It's just Dandy-Walker variant without hydrocephalus. Another dilemma that the family or obstetrician have is that they need to be delivered at the tertiary care center, If the child is adequate gestational age, they can be delivered safely at their place, They don't require ventilatory support or thing immediately at birth. 20-week gestation, hydrocephalus, vermian aplasia, Dandy-Walker malformation. You see this here? It's clear. Okay. The family, because of the religious region, they continued the pregnancy. The child was delivered. And the child had this. Encephalocele. Okay. So you have an encephalocele. Probably because the child's head was compressed towards the uterus, internal wall of the uterus, so it was not picked up on a scan. Okay, and big posterior fossa cyst and hydrocephalus. Okay, so what we did was then encephalocele repair. First we put in a shunt and then encephalocele repair. This is a brain tissue that was dissected from the skin and was put back into the cranial cavity. Doctor couple, 30 weeks gestation, diagnosed as Dandy-Walker malformation. They got a fetal MRI done. Okay. There's a quick cyst, Vermean agenesis, and then attended hydrocephalus. Okay. What is the prognosis? What would be the IQ, mental IQ? That's what the family is very clear, They have 2 or 3 questions, blunt, sharp, not blunt, sharp. And that we have to answer. We can't tell them, nahi dekhte hain, paida hone ke baad mein kaisa hoga, aisa, waisa. Okay. Another very important thing, what I want, the size of the cyst doesn't correlate with the IQ. The hydrocephalus doesn't correlate with the IQ unless it is not treated appropriately. Okay, you see, this is the scan done in postnatally, almost 1/3 of the intracranial compartment, Okay, this is an axial scan. We did a cystoperitoneal shunt. Okay, you see, the brain has started growing back. There is a shunt. There is absolutely no hydrocephalus. So just because you have diagnosed that antenatally doesn't mean that there's the end of the day. They have a chance. We have to give them one chance, one good chance. Unless the family doesn't want. There's no force. Last example, 28 weeks gestation, posterior fossa cyst. Again, you see this? 4th ventricle communicating with the cyst. There is no vermis. Okay. This is a postnatal scan where the child also had corpus callosum agenesis, This has a bad prognosis. This I would send it to the genetic specialist, Okay. Sometimes, antenatally, when they do the sonography, in spite of their best efforts, they miss out some things. It's very difficult, And again, the ultrasound is an inter-operator difference, It is an operator-driven investigation. Pardon? No, see, there is no surgical role for the further pregnancy and all those stuff, Better to see a genetic specialist. Okay. Okay. This is again a posterior fossa cyst. Okay. There's a plane. You see the cyst over here, antenatally diagnosed. There's a fetal MRI that has been done. Now here you see the brainstem vermian angle is not big. You see this here? And the cyst is asymmetrical, is on the one side, not in the midline. A diagnosis? The posterior fossa arachnoid cyst and has a very good prognosis. Okay, this is a postnatal scan. You see the cyst has got compressed. Again, this is the scan done at day 10 of life. There is no need of surgery at this moment of time, there is no hydrocephalus. We followed up the baby, the child had a large head, increasing head circumference, and now you see the repeat scan shows that there is a gross hydrocephalus, and that is where the shunt has to be done. And the important take-home message is that the moment it is diagnosed, it is not that the neurosurgical attention would be needed immediately at birth. Okay? Last case, again posterior fossa cyst, you can see the cerebellum. What is this? This is remnant of pouch of leg cyst actually. It is not Dandy-Walker because we can see the vermis very well. Okay, but it has remained it and it's benign condition, nothing to worry. So take home messages, for this antenatal things. USG remains our main tool, Any CNS abnormality, that's the rule of thumb, They have to do it again. Recheck, retick their marks, If you are not getting all the parameters at one go, repeat it. If you have a complex deformity, then a fetal MRI is helpful. Okay. In our country, ultrasound still remains the main tool for ventriculomegaly and hydrocephalus, we have to rule out, if it's not colposcephaly or ventricular megaly, where any ventriculomegaly, I would be very happy if there is a report, biparietal diameter and head circumference. most of the good sonologists or fetal medicine expert would definitely put it. We need to know the cause of the hydrocephalus. Anything that is happening late in the gestation, we need to know why it has happened suddenly. And rate of progression is also important in the prognostication. Okay, for posterior arachnoidosis, there are only 4 diseases that we see, and how we can differentiate is a brainstem-Vermeer angle. If somebody tells you the brainstem-Vermeer angle, that's it. You don't need more information also. 80-90% of the work, the diagnosis is done. Chalo, good outcome if treated appropriately. Just because hydrocephalus has been diagnosed, just because Dandy Walker has been diagnosed, doesn't mean that there's a bad prognosis. Not all intracanal pathologies have bad prognosis. Just because in our past experience, sometimes we have seen the hydrocephalus child didn't recover, required multiple shunt. So as a philosophical or something like that, you will say, nahi, kya ko shunt karata hai, baar revise to karna hi padega. It's not fair for the child. That's it.
So thank you for an excellent overview. We have questions.
Muscle-eye brain disease can be possible. MEB is possible. Muscle-eye brain disease.
No.
So Joubert also.
With cataract? Huh?
Not Joubert you're talking about.
Marfan syndrome?
There is a syndrome with silver. They're asking you for cataract that you may have to change the genetic testing.
So pontocerebellar hypoplasia types have many types. A few types have cataract.
So rare.
Okay. Any questions? Actually, the intention was of keeping this topic is first we have to late gestation when it happens 24-28 weeks when we discuss cases with sir that we are not going to do CVS amniocentesis most of the times. The baby is about to be delivered. So it's not that we are doing any genetic diagnosis immediately. So first is prognosis and any post perinatal management is required and sir tells immediately कि ये genetic लग रहा है. इसको genetic लगेगा, I am not going to touch, genetic investigation करा लो. And sometimes he says that no, this is completely manageable, non-genetic, brain is good, the child is going to recover. So that distinction has to be there with
No, see, antenatal counseling is all teamwork actually. It's not like my patient, his patient, their patient.
Yes.
So what we try to do is that we take the obstetrician, the neonatologist, the genetic specialist, everybody in confidence, and then talk to the family.
So sometimes if brain is getting damaged because of increase in hydrocephalus than structural abnormalities, then it is more likely non-genetic, like we say cases.
Yeah.
And if there is structural abnormality associated with it, then you more focus on genetic, but still you have a chance that if there is any curability or improvement, because as in partial callosilogenesis, not all children have very bad IQ or very bad mental retardation.
That I have not, that is a pure neurology topic actually. I have not touched that. But again, corpus callosum agenesis, what we see is choroid plexus cyst actually. I should have mentioned that. The choroid plexus cyst, the sonologist right, the 10 millimeter, 8 millimeter choroid plexus cyst, and the obstetrician starts getting convulsion, इसको continue करूँ क्या नहीं करूँ, क्या होगा? And that's perfectly benign condition, perfectly benign condition. The only thing that we have to rule out is that even on the ultrasound also, we just make sure that the the thumb is not broad and the angle is open. Suppose they give the report and the thumb is in the clench, so it is good. And we just rule out that there is no congenital heart disease. The risk of trisomy 18 is much higher in choroid plexus cyst. Otherwise,
so that is what, sir. With 20-22 weeks, we are doing invasive diagnosis.
No,
we are doing karyotype microarray.
Yeah.
The problem only comes when it comes after 28, 30, 36 weeks, where we have to know that whether it is genetic, non-genetic, what is the prognosis, curable, non-curable, where neurosurgical opinion is definitely needed before pregnancy. So that sometimes MRIs are also avoided post-pregnancy. Immediately may not be needed. You just have USG brain, you follow up the child and then do MRI maybe 6 weeks, 8 weeks, 2 months of age. So not immediate.
Intervention. Have you done any fetal intervention, fetal shunting?
No. The place in North, I was in San Francisco in 2009 And I was in a different center, but I visited the place where the mom's trial were done, antenatal repair of the meningomyelocele. But the results were not as good as they were expected, and they abandoned they had to prematurely close the study in 2014. 13 and 14 they closed it actually. I have attended those labs and have seen one of the consultant operating, but that is a different topic actually, antenatal surgeries and all those stuff. If you have time, I can discuss it.
Can I say something?
But all I can say is that it is still not mature enough or it is safe enough to be offered to our children or mother. The complication rates are so high that it is not worth it.
Okay, I would like to just say one thing. Whenever we talk about geneticists, we always think about identifying the gene mutation, but recurrence risk, because preventive measures. Now, if there is repeated, you are into neurosurgery, maybe spina bifida, repair expert. But if there is a family history or recurrent neural tube defect, there can be a deficiency in the MTHFR gene. I mean, there is a mutation, MTHFR gene mutation. So these studies must be done in order to estimate the recurrence risk, because as you know that neural canal starts developing at say 17 to 20 days of gestation.
26 days the primary neural core is done actually.
That's what I'm saying.
Much,
and then
early.
It grows caudally and rostrally. But still, like for the recurrence risk estimation, it's very important. If there is any family history around the axis, anytime if there is any neural tube defect, then to look at the MTHFR, irrespective of your folic acid, irrespective of all your B12 levels, there is a possibility. And then whatever amount of periconceptional, say food, fortification, I mean having periconceptional diet of fortification of food or folic acid supplement is not going to be sufficient. So they will be at a higher risk and one must start evaluating as early as possible.
Now, since we have... No,
I'm just saying...
I'm trying to control myself, but once madam has started, I'll just put up 2-3 points.
Yes.
All spina bifida is not meningomyelocele.
Not at all.
Yeah, we need to understand. When we are talking about spina bifida, we are talking about a big gamut where there was no MRI, no CT scan, and we would see on the X-ray that the postspinal elements are not there, and we would have labeled that as spina bifida. Now, the best thing that we have to speak is the tethered cord syndrome. You have an open neural tube defect and closed neural tube defect. Now, the madam, what was trying to give the gene is all for the open neural tube defect, and hardly we see them in our practice. Okay, closed neural tube defect, the diastematomyelia, the lipomeningomyelocele, the neuroenteric cyst, dermal sinus, dermoids, they have a very good prognosis. Okay, even if they are diagnosed antenatally.
You are seeing adolescents and adults coming to you.
Yes, no, that is different. Just because one child has diagnosed with spina bifida doesn't, suppose a child has a diastematomyelia, bony spur, that was prophylactically treated and is doing good. If the family wants to conceive another child, the child doesn't have a risk of the disease at all. It's like just common population, what is the risk?
Common population.
Yeah, it is same risk.
Background risk if it is non-genetic.
Yeah, it is just like non-genetic. Second thing that madam put it to attention was that by the time the UPT is positive and then the folic supplements are started, it is too late. Any planned conception 3 months before prior to the thing, the folic acid supplement has to be started.
So even in spina bifida,
Periconceptional is very important. But any additional family history of neural tube defect,
Then that needs to be investigated.
one has to. That's the importance of family history. Thank you.
Thank you, sir. Sir, I want to felicitate you.
Yes,
Sir, would
if
you?
there is family history, then definitely yes. I mean, you don't do
So would you?
anything by doing it.
Would you? Sir. Thank you, sir. If you can put on lights.
Slightly comes. Perfect.
Thank you, sir. Thank you. So for occult spina bifida, Dr. Naresh Bhyani is so excellent, there would be another talk needed for his case collections. We are moving on to Dr. Vipin Pathak is there, otherwise we will finish. He's come.
So we will just a slight change. We will have communications with parents, the session, Dr. Vipin Pathak session we'll have after this.
This is a quick session where we have few scenarios when parents either come to pediatricians, obstetricians, they want to know both of their opinions. So a quick review of few situations where obstetricians and parents need to give this advice to parents and have to have this communication well. For example, we will have this session with me and Gauri because Gauri is there who counsels. So parents with a child having undiagnosed condition who want to plan pregnancy. This is so common because uptake of genetic investigation is slowly increasing. But we have many of the times that first child is undiagnosed, or just we discussed that autism, but there is no diagnosis, genetic diagnosis, or any of the condition, mild mental retardation, disability. Apart from that also just a congenital heart disease, otherwise the child well, and we do not know whether it is genetic or non-genetic. So undiagnosed condition who want to plan pregnancy. So first would be whether it is genetic, non-genetic. So that question comes to pediatrician's desk or obstetrician's desk. If they come for preconceptional advice to obstetrician, they ask obstetrician whether we will have recurrence of this condition in our next pregnancy. And to pediatrician also the same question will be asked by the parents, that we have this child affected, mild autism, mild delay, or some abnormality was detected, congenital heart disease was corrected, or we had some abnormal scans. So what to do in this case? So first question is genetic or non-genetic, which has to be decided right at that time, not after, because uttering word genetics and referral to geneticist also comes with its own risk and taboo. So sometimes that fear is always there in pediatrician and obstetrician's mind, whether I should tell this as genetic and refer to a geneticist. So that confidence has to be there. Clinical history, examination, investigation into the etiology. Most of the times we have clinical history, some examination findings on the paper, but investigation into etiology are incomplete. Sometimes investigation uptake is not well. Sometimes we just do a karyotype or microarray negative, or some investigation phase has come negative and case is stopped at that. So it remains undiagnosed. So investigation into etiology are must, and confirmation of genetic etiology is must. So that is why we are having this session just as a communication point of view. We are not going to details how we do genetic testings to confirm etiology depending on the case. So these are the points which have to be mentioned during the communication. These points have to be discussed with the parents, that first is we have to see whether your child has a genetic condition. It comes with good clinical history, examination points. If there are associated points which which increase the risk of this condition being genetic, then it can be communicated to the parents. How much they are willing to have genetic investigations, uptaking those genetic investigations. Final confirmation and calculation of risk of recurrence. Preconceptional counseling, management, and prenatal advice. So these are all the points when a parent come to us. This is one situation. Then another situation is parents with a child or family member with known genetic disease, be it any thalassemia or any condition who is treatable, and they want to plan the pregnancy. So here we have, sometimes paper just mentions that query Down syndrome, or query some family member with query muscular dystrophy, query Duchenne dystrophy. And sometimes some clinical notes are there, previous child died of query joint deformities or had some contractures. Then here also confirmation of genetic investigations may or may not have been done. Calculation of risk of recurrence is important, and again same points can come to a desk of pediatricians or obstetricians discussion. Then we have one more situation. These are 3 common situations which we have taken, that parents to a newborn with positive screen of a genetic condition. So we have now screening, almost many corporate hospitals, newborn hearing is being done, newborn screening for IM is being done, and newborn screening for congenital heart disease is being done. So these, and any of these can be a genetic condition. So any positive screen report may not be diagnostic. So if that comes to us, that whether this positive screen report, genetic or non-genetic, whether we should go ahead with the investigations. Repeat investigations whether are needed in our child depending on the screen report. And sometimes even after confirmation, we may have some doubts because if a condition is, say, congenital heart disease and the heart disease has been repaired, say VSD or any complex congenital heart disease. So we are not in a position to tell prognosis sometimes unless we have a genetic diagnosis at hand, whether it is 22q11 or whether it is syndrome which is not apparent in this newborn or dysmorphic features are not apparent. So there we have to have a continued evaluation on follow-ups, whether there is continued risk of the same findings, whether there is any increased risk because of additional symptoms or signs in the child or evoluting dysmorphism, evolution of new findings, some seizures or some developmental delay unexpected. Positive screen was there, confirmatory investigations were done, biochemical and they were negative, but there are some new features coming in. And on general monitoring, child is lagging on growth and development. So here also counseling. So these mainly three situations where pediatricians, obstetricians, geneticists also are stuck, where we need sometimes repeated counseling, visits of patients, loss of follow-up, and we also want to know how to communicate whether this is genetic or non-genetic. So this is first case scenario where there is some family history, diagnosed, undiagnosed. So this was the family where the mother came to us. This is a common disease and very easy, but we have taken this as a situation. So this is the mother who has come to us, and she has brothers died in her family in early 20s. Clinical suspicion was done depending on the clinical scenario. Some written that query muscular dystrophy, and always sometimes X-linked muscular dystrophy is taken as Duchenne muscular dystrophy. So somebody has written on paper query Duchenne muscular dystrophy. So earlier people used to do muscle biopsy. The brothers have died during early 20s, so usually it is taken as Duchenne muscular dystrophy. So clinical suspicion findings have to be confirmed whether there was any CPK level done or muscle biopsy was done if genetic diagnosis was not done. And if genetic diagnosis, nowadays we are storing DNAs of dying patients even in adults. Even in adults, sudden cardiac death, even in adults, sudden death because of unexplained death, we are advising DNA storage. And of course in pediatrics has to be done. So if any DNA diagnosis was done or DNA is still stored, in this case, so if we have to take Duchenne muscular dystrophy, it is X-linked, which gives you the clues that males were affected. CPK is high. Even if we get a note that CPK was high, sometimes we are so sure, and now we can do, even if DNA diagnosis was not done, carrier screening of females is available for Duchenne muscular dystrophy. Sometimes if we see a report that males were affected but CPK was normal, then obviously this is not Duchenne muscular dystrophy. They may have some biochemical report, but no diagnosis, no muscle biopsy done, no DNA diagnosis done, but CPK was normal, and there is death early 20s. So there are so many other muscle dystrophies which we have to deal with, and there only female investigation will not help. Now the brothers have died or the males have died. So here CPK normal, but there was or mildly elevated where we don't suspect usually Duchenne muscular dystrophy. It may not be X-linked. It may be some other muscular dystrophy which has been presented, which was there in males, but it was taken as X-linked. So here you have to review the clinical notes, talk to the parents of who have died, whose children have died, and if there is suspicion then that there is another muscular dystrophy. Nowadays we have couple carrier screen where we offer carrier screening for muscular dystrophies to father and mother, and if there is a common mutation of any common condition we can pick up. So there are different tests available for different disease diagnosis, and hence these points have to be kept in mind. If index case is not available, how we are going to approach and communicate. If DNA is stored from any of the family member who was affected, and can we do, if nothing is available, and if nothing is known, can we do some carrier testing in parents? Still it is available. That is what I wanted to say. So Gauri will tell us what can happen in some of the X-linked disorders which... DNA storage can be done in 1,000 rupees, minus 20 degrees with all the laboratories now. If you request some of the patients not affording, we have research institutes doing DNA storage for free. We have DNA storage, we have done 300, 400, 500 rupees where patients are completely not affording ICU. Parents want to take the child out of NICU. If physician was interested in diagnosis, parents not. So we just requested, please can we get some EDTA blood, and they don't want to pay. So doctors paid actually for DNA storage. We are doing it. No. So I just, this was an overview, but if CPK is normal, we have to review if this was really muscular dystrophy. CPK is normal in some of the congenital muscular dystrophies and myopathies. So that is why. So there may be overlap. It may be muscle dystrophy, it may be muscular like Duchenne's, or it may be myopathy or congenital muscular dystrophy where the child was growing, the child would have contractures, but because heart was affected, the death was because of heart failure rather than any of the muscle dystrophies. So here clinical notes would be very important. Nowadays we are getting those clinical notes. But we have still parents where some of the family members have died in early 20s. Nowadays we have those CPK sometimes, and muscle biopsy is not being done now in DMD. So we do DNA diagnosis. But in 1%, less than 1% cases, DNA diagnosis, genetic diagnosis comes negative in even if it is DMD. So there we need muscle biopsy in the patient. There the DNA diagnosis will not help. So there are cases where we have to deal like this. So that is what, if nothing is there, that just says that we have 2 males died, and now we fear that every male, whether we have male in the child dying, whether this is X-linked. So here it is, apparently we can say that this may be X-linked. You can get a screen of X-linked disorders like Duchenne muscular dystrophy or X-linked conditions associated with such diseases. But if they are absent, that doesn't mean that it will not be there. And you can have a screen for autosomal recessive diseases by couple carrier exome screening. So that is the counseling which our pediatrician obstetricians can provide, that these are the options which won't be definitive. There are still cases that it will come negative.
So in follow-up with what Dr. Snehal said and your question, why it is very important to take the family history and why it is very important to take the, so like we say in counseling, you need to take 2 to 3 generation family pedigree to understand. Sometimes we get an idea of what kind of pattern of inheritance the condition is following, and through that we can also understand what genetic testing could be or should be advised, what line of testing, because doing something where CMA is needed, an exome sequencing is not going to really give you a yield. So as in this pedigree you see clearly that males are affected. So it follows, like we have now just discussed, X-linked pattern. So if only males are affected, it is likely to be an X-linked recessive condition. Females will only act as carriers, or we call them as obligate carriers, and they may remain unaffected. Affected males will have all carrier daughters, and fathers cannot pass the X-linked recessive condition to their sons. So these are certain criteria, which you can, of course we can't expect the clinician to sit and take pedigree, everything, etc. That's why geneticists and counselors are there. But just to sort of have an overview, these are certain sort of flags which can be noted.
And we have some conditions where you can tell us, Gauri, X-linked inheritance where the disease is not severe, and how to deal with such cases.
So for example, conditions like G6PD, you have again milder form of X-linked inheritance. So there you have to, of course, clinical evaluation through, like many a times newborns may present with hyperbilirubinemia, or again it is of course late onset as well in adults also. So many a times there is an ethical dilemma of testing, of prenatal testing, especially when in milder conditions. So again in that situation also counseling is very important. Genetic counseling is very important to explain the patients and the families, the parents, the couples, the mode of inheritance, the risk, recurrence risk, how severe that particular mutation what is the severity of the disease for that particular mutation. So all these communications we...
because in conditions with G6PD which is benign and it is seen in males, and we have just discussed that there is increased surge of cases of autism which is seen in males. So we get G6PD positive on newborn screening, and this child comes with say autism or developmental delay, and then there is always a question that we have this G6PD, madam isme positive aaya hai. So is there any another genetic disease in my child which is responsible for the current condition, and whether we should go ahead with a genetic diagnosis? Because what happens is, once you get that G6PD positive on newborn screening, many of the laboratories are directly doing exome for mutation of G6PD. So in that case, you may have sometimes dilemma of getting a variant which is being noted on exome sequencing, which we have not addressing today, which may pose dilemma कि ये disease भी आगे जाके आएगा कि नहीं. I mean, you must have looking. That is why we are discussing few of the situations where X-linked is benign condition like G6PD, child is having hyperbilirubinemia, or NICU admission, prematurity, some query birth asphyxia, some mild mental developmental delay. So whether any mix of other genetic conditions. So this pedigree is important, and interpretation of investigations is very important. So communication at every level before planning pregnancy, investigation have to be completed till we have a confirmed diagnosis. Explain possible inheritance, and as Gauri is usually handling counseling sessions which are repeatedly needed in prenatal diagnosis.
So we need to have counseling sessions at every stage, especially when we are talking about prenatal diagnosis, right from the stage when the couple comes, like if there is a known condition, they are planning for pregnancy. So right from that moment, interpretation of the report, screening, whether we should do, what are the stages of screening, NIPT or, then invasive screening, and then stepwise. So at every stage, there is counseling, and like we have written here, preconception management and prenatal diagnosis and management. So how can the couple go? So it is not just one counseling session. There are multiple counseling sessions at every stage of the management that we have to undergo with the couples and the families.
Yes, I can be.
Yes, ma'am.
In between interview or later?
Yes, madam.
We have got cases with DMD, though it is X-linked, females with DMD. So if you can add something, we have got a recent case, I think Michelle actually tell you more about it. And also when I was taking training in Edinburgh, first big poster was put on the landing staircase that do not forget that DMD can also happen in female. Parag also must be knowing cases. And also DMD carriers, female, may have cardiomyopathy later, so we have to counsel patient's mother also, like because if she is a carrier. So I think Michelle will tell about the case if you allow.
This case was very interesting case which we had a 13-year-old girl diagnosed. 13-year-old girl diagnosed with the Duchenne muscular dystrophy. When we did our deletion duplication studies, there was deletion between exon 45 and 50, and when we did a karyotype, there was X7 translocation involving the same region. So most probably this we thought, now we are doing parental karyotype to find out whether one of the parent is a carrier of an X7 translocation. So most probably one of the X chromosomes is having a deletion, and one of the X chromosome, because of X7 translocation, there is an interruption in the same gene. That could be the reason of the female being affected with classical Duchenne muscular dystrophy. So karyotype is important to look for the disruptions of the X chromosomes in DMD cases also. Yeah, all X-linked, yes.
And we have Leon hypothesis also, where there is X-linked inactivation which presents, and it can be tested, but in research laboratories. So what I'm trying to say that we have to have a confirmation about this clinical phenotype, why it has happened. Gauri will tell one case where we have G6PD positive, the child was autistic, we got so many variants on the report, and how we go ahead with communication and counseling and work about such cases.
So we had, there were I think 4 variants that were...
One variant of G6PD.
One variant of G6PD, and there were VUSs that
variant
was,
of uncertain significance.
So VUS is variant of uncertain significance. Of course, one part of counseling is whether to sort of help them understand what is a pathogenic variant and what is a likely pathogenic, what is a variant of uncertain significance. So a lot of, I think, clinical correlation is necessary.
Because G6PD, we are doing exome sequencing. So we are likely to get some variants which may not be explainable or have to be explained with further parental karyotype, and parents are saying that X-linked inheritance G6PD to hona chahiye, फिर ये दूसरा condition, whether this is autosomal recessive or not, why it is so, we have to do couple carrier screening. So the point here is the clinical notes of pediatrician, obstetrician, geneticist have to be complete with what communication points have been communicated with the parents, what were their questions. Usually we tell them that even if we have one question, you please come with with your queries or questions written on a paper, and we will address one by one. Vishalakshi is saying, because sometimes there are more questions after our discussion. More questions after the session. So if they write and tell us that what is the precise query, then we can deal with those queries precisely, or if they are interested, further investigations can be done.
Dr. Snell, I don't understand, but why do we need exome sequencing in G6PD?
नाही, एक्झोम करतात ना. एक्झोम सिक्वेन्सिंग म्हणजे न्यूबॉर्न एक्झोम आता असं आलंय की G6PD पॉझिटिव्ह आलं आणि काही लॅबोरेटरीज न्यूबॉर्न एक्झोम करून देतात रिपोर्ट. So I'm just saying that we have to know which conditions we are going ahead with genetic diagnosis, whether it is needed. Sometimes G6PD positive is there and hyperbilirubinemia is there. So what you would like to know, whether this is G6PD, which is very rarely manifesting as hyperbilirubinemia. Then you would evaluate family also sometimes. So in such cases, if exome is done and you get some variant. So there are, I mean, these are the situations which are usually dealt with. Then there is one scenario which is,
this 31-year-old had full-term normal delivery. Child was 2.49 kg and elevated glycine levels at 48 hours of life were observed. Then repeat.
Glycine level.
No, sir. Newborn screening is now done for every baby. No, newborn screen is done for all the IMs now in most of the corporate hospitals in Apollo also. So in newborn screen we got increased glycine levels. Part of the normal newborn screen, sir. Yes, sir. Bright blood spot. No, normal newborn screen.
The entire one, the 25.
50 disorders.
Glycine is
Glycine was high, so that is why the patient baby was referred. Nothing, no positive history, completely full-term normal delivery, normal baby.
And then NBS was repeated at 17 days of life, and repeat screening glycine levels came normal.
But the questions here were that NBS is always repeated usually by the laboratory when any positive thing comes on paper. But hyperglycinemia, NKH, Parag is here, that sometimes nowadays we hear so much of mild, moderate, severe disease. So some diseases where we have mild presentation can come in infancy, sir. So where we have hyperglycinemia presenting as mild delay around infancy, late in gestation. So Parag also can give his views here that some of the conditions which are associated with neurologically bad prognosis, and we get some findings here, we need repeated sessions, whether we should go ahead with repeat glycine levels, CSF glycine levels. The current protocol says that you have to do plasma glycine and CSF glycine if plasma glycine is high. In this child, we are still monitoring because parents had so many questions about neurological prognosis of this child, even if glycine levels come less, and whether we should monitor a diet. And if such child gets a febrile seizure or a seizure, then the questions arise whether we are still dealing with mild hyperglycemia. So the child is being monitored by pediatrician for developmental growth and development. We didn't do CSF glycine because plasma glycine came high. But if there is even milder problems in the biochemical investigation, sometimes we do have to do repeat biochemistry, plasma levels, CSF levels, MRI sometimes as an baseline, not in this condition, but I'm just saying, yes?
If it is more than 500, then it is a little bit more significant.
More significant.
For further tests.
Yes, and sometimes we may have to do CSF glycine. This child, we needed 2-3 sessions for parents with for counseling that we don't have to do CSF. Please don't do. Parents were pressing that we will do CSF and let us confirm whether it is going to harm our child, because neurological prognosis in hyperglycemia is really bad.
So further workup, and follow-up, especially, what is the kind of follow-up that should be done and can be done, especially in terms of, counseling. So maybe Madam or...
I have a question, because I just want to reiterate this, that in all these metabolic disorders, when you get something abnormal, and you're doing an MRI, please do an MRS.
MRS, yeah.
Please not, it's the same thing, and you can do a spectroscopy. And if a glycine peak is also seen, and the levels are high, then you may have to do some kind of earlier intervention.
Yes,
I mean, there is very little that can be done, but dextromethorphan, by the way, am I right? Dextromethorphan is one of the drugs which is being used. And we've got a series of 3 patients published where we have used this.
Yes.
On MRI, MRS showing high peak. Then we did a CSF to plasma glycine. So the level of CSF glycine is higher than the plasma glycine.
We took these situations where communication is needed at primary level, sir, where child may be normal, or you may have to do some investigations, and communication of genetic disease may be a problematic. If it is diagnostic, then there is no problem. Then they follow up well, and we have to put a stop. We have already put a stop. But there are sometimes many queries, like in these 3 situations: undiagnosed first child, family member, there is no confirmation diagnosis, or some positive newborn screen, systemic abnormalities which are not very detrimental for mental or growth and development, and still questions are coming whether it is genetic or non-genetic. These approaches should be taken up by pediatricians, obstetricians. Notes should be clear, and how to progress ahead with investigations so that we confirm the genetic diagnosis if we are suspecting genetics. Dr. Vipin Pathak has come.
Dr. Vipin Pathak is... yes.
Yeah, Dr.
Just a query from general pediatrician point of view. We get so many idiopathic seizure disorders who have all investigations normal. So could it be some mutation related?
So seizure disorders, now we have epileptic encephalopathy genes. So there, if investigations are normal and still you are getting outcome or other problems, then we are doing those either gene panels or exome sequencing. So it depends on the child's phenotype actually, but as you are saying that everything is negative and whether genetics, we are going ahead with genetic investigations. I mean, Dr. Shekhar and everybody, they are doing epilepsy gene panels either, or exome sequencing nowadays, because rather than gene panel, the cost is same. So we are going ahead with exome sequencing. So we can that communication can be started with the parents. That everything is negative, but there can be genetic which only presents with epilepsy, and you can go ahead with investigations, because तोच क्वेश्चन असतो बऱ्याच वेळा की हे जेनेटिक आहे का, बॅड प्रोग्नोसिस आहे का, आणि मग पुढच्या बाळात पण असंच होणार का. Because even if the child's mental status is normal, epilepsy is under control, question will be genetic आहे का, पुढे आमचं बाळ मेंटल प्रोग्नोसिस कसं होणार आणि पुढच्या बाळात येणार का. So here a lot of questions and communication is needed to go ahead with genetic investigations. First, why to go ahead, and in case after genetic investigations, if there are unanswered questions in the report like VUSs. So these difficulties have to be encountered and continuous dialogue has to be there. So isolated VSD, actually we had one case where we wanted to address this in case panel, but isolated problems or systemic abnormalities like congenital heart disease असू दे, नाहीतर esophageal atria, pyloric stenosis असू दे, जिथे isolated problems but otherwise child is normal, whether it is genetic, non-genetic. So there are some syndromes like you say heart disease, 22q11 is so common, and 22q11 comes without any abnormality also. The child, the family member is carrier, completely normal. So there are some microdeletion duplication syndromes or some syndromes where you can get isolated problem, just hypocalcemia, just heart disease, which can be communicated to the parents that we can screen for these abnormalities, which can be severe in the next pregnancy. So that communication can be done. And if it comes negative, then there is a background risk, as we say in heart disease. But completely saying no to genetic investigation is becoming increasingly harder nowadays, because parents want to take up genetic investigation की problem आला तर नाही पण negative आला तर जास्त बरं पडेल. We have Dr. Vipin Pathak, who is head of the department here in radiology, and we wanted to have, because after Dr. Naresh Biyani's talk, we immediately wanted to have some overview, but he's reached now fetal MRI and neurosonogram, and he has excellent images. We are doing fetal MRIs here, and Sir didn't touch Dr. Biyani about neurosonogram, which we wanted to discuss, Dr. Vipin. So that is why we wanted to keep this MRI spotter session. Thank you for coming.
Thank you, Dr. Snehal, and I welcome you to this wonderful session of genetics. So my talk will be basically a case-based approach where I will be showing you some cases where I have done both sonography and fetal MRI. So before I start, I would just like to brief that I am doing this fetal MRI for last 13-14 years and doing that ultrasound for last 16-17 years. So I have seen a lot of change as far as fetal medicine is concerned. Previously, you used to do only ultrasound on a basic machine where we don't used to have color Doppler or 4D kind of facilities. There was nothing like NT scan or all kind of screening method that we have. So we used to get lot of cases in the second trimester, all kind of theoretical cases that we study in our book. But over a period of time, because of this genetics and NT scan and all those kind of screening method, we rarely find those kind of cases at present. Whatever we find that in the first trimester, and I rarely get any significant congenital anomaly in the second trimester, especially in Navi, Mumbai, because we have a lot of screening procedure now to rule out that kind of anomaly even in the first trimester. So these are the few cases where I have done the sonography and fetal MRI. So let's proceed with the cases. Case number 1, a 28-week fetus with disproportionate provenance of occipital horn on sonography. So 28-week fetus with finding of isolated bilateral mild ventriculomegaly on the sonography. Fetal MRI was done to confirm the diagnosis and to detect any additional abnormality. The past history was 2 miscarriages after 1 full-term normal delivery and history of mild PV bleeding and UTI in the present pregnancy. So that was the history. The patient has ventriculomegaly and history of miscarriage. USG images, you can see this is the dilatation of occipital horn that we call colpocephaly. And the measurement was beyond that limit, 11.7, 10 is the upper limit for ventriculomegaly. The spine was absolutely normal because whenever we find any abnormality in brain, we should see the neurospinal axis to see if there is any kind of abnormality in spine also. But on ultrasound, there was no abnormality in the spine. I tried to find any other abnormality, but except that, nothing much was significant. So, MRI. Now, I use fetal MRI as a problem-solving tool because we can't take the pregnant lady directly to fetal MRI because there should be some clue on the ultrasound where we need to additionally find some more findings to conclude. In majority of cases now, ultrasound is able to come up with the diagnosis, but in some cases, we need the help of fetal MRI to come to the final diagnosis, and this case was typical for that. On fetal MRI, I have a lot of images. I will just scroll fast so that you can understand. Again, there was a finding of dilated occipital horn that we say colpocephaly. In addition to that, we found some hyperintensity also near this globus pallidus area. You can see this. This one is some hyperintensity in globus pallidus. Now, this is the axial images. I am showing you the coronal images. Coronal images, you can see these 2 bright structure. I know a lot of people are not a radiologist here, but you can see these 2 bright structure adjacent to lateral ventricles are hyperintensity in globus pallidus. And of course, colpocephaly. Sagittal images, same. So, in summary, the patient has colpocephaly, no other abnormality, brain, spine was normal, and on MRI, there was hyperintensity on globus pallidus. So what is the diagnosis? We concluded that it is an inborn error of metabolism. Why? Because this globus pallidus involvement is very common in these cases. Now let's understand what is inherited metabolic disorder. We have 3 patterns: gray matter disorder, white matter disorder, and disorder involving both gray and white matter. In gray matter, we have 3 patterns: predominant cortical involvement, predominant deep gray involvement, and then deep gray and associated white matter involvement. Predominant deep gray matter involvement can be either corpus callosum or disease involving globus pallidi. In our case, it was a globus pallidi involvement. Now, if there is involvement of this caudate and putamen, then we have to rule out all this syndrome, Leigh syndrome, Mela, Wilson's, glutaric aciduria, juvenile Huntington's disease, etc. Disease involving globus pallidi, then we have so much of differential diagnosis. Our case involved both globus pallidi and corpus striatum. That is, caudate and putamen combines to form corpus striatum and globus pallidi. And the differential for this. So I am in touch with this patient to understand what is the diagnosis. Actually, the patient was an eye patient. She lives in Australia. So we are in follow-up with the patient to know what kind of diagnosis is finally made after the birth. But this is the final diagnosis that we concluded after doing fetal MRI. If you had not done fetal MRI, we would not be able to conclude to this point that the patient has involvement of globus pallidi, and we narrow down to this much of diagnosis. So this is the additional advantage of fetal MRI, because on ultrasound there was on colpocephaly, nothing else, but on fetal MRI we precisely understood that we had a hyperintensity in globus pallidi with this much of differential diagnosis. Yeah, actually the patient lives in Australia. We are in touch with her, unable to communicate with her because the number she gave me, we are unable to contact her. We have written a mail also. So I told her that we want a feedback regarding that. So we are in touch with her, but I am suspecting this DD. What will come, I will let you know. But these are the diagnoses we are expecting because globus pallidi is involved, and these are the differentials for that. And the patient has history of miscarriage, PV bleeding, those kind of things were there. So we are in touch with the patient because she lives in Australia, but we will let you know once that comes to her. But what I want to emphasize, on ultrasound, we would not have been able to cone down to this much of DD. How will you say on the basis of colpocephaly what is the differential? It was because of MRI we coned down to this differential. That is the main point I want to emphasize. See, colpocephaly hai, you delivered the baby, that is a different thing. But in the womb, if you can cone down to this kind of differential, then it's a big thing now. Now, patient was living in Australia. I told her you can get all those genetic testing, whatever can be here, but she has to go back, and we are in touch with her. So I will definitely let you know regarding that.
And one advantage of bringing some of because this family had abortion.
Yeah, correct.
There is a chance that sometimes such babies, if delivered prematurely, the problem in interpreting a newborn screening report, the problem that now this patient was affording, but the patient is getting delivered where NBS is not routinely done for all IMs. Sometimes they are doing only for 5. So sometimes advantages of such cases where we can follow up in prematurity also, then we can take up a definitive diagnosis and just not do NBS, which may be inconclusive. So that is a advantage of doing some of the neurological abnormalities with MRI and additional information.
Correct. And the problem with fetal MRI is not widely available. A lot of centers are not doing because of the nagging PCPNDT and a lot of issues like fetal movement. It is a technical thing. It's not like that if you are not comfortable in doing your head scan, you will get a sedative, you will get sedation. But how will you control the movement of baby? There are techniques I will emphasize at the end of my talk, because you cannot control the movement of baby. Then sequences, then a lot of issues are there. So a lot of centers started doing fetal MRI and stopped. Even Bhavin sir started and stopped. Because, see, at the last, you want to earn if you have a private center. So people don't want to take that much of effort. They will do 10 head MRI in that effort. In institute also, I think few of the institute are doing it nicely. In Mumbai, there are 3-4 big hospitals they are doing. In Navi, Mumbai, I am doing, I think MGM is also doing. So this is something where you need to understand what kind of a scan you need, what kind of sequence you need, and then the mobility of the baby and the sequences. So it's quite a difficult thing, but we should try. So in the second case, a 33-week fetus with cystic tubular structure in midline with vascularity in the brain on ultrasound, suggestive vascular malformation. Actually, in this case, the diagnosis was clear on sonography, but we did MRI to understand what additional information we can find. So USG image, the infratentorial structure was normal. Now, you can see there is evidence of well-demarcated long tubular structure in the midline, this one. Just go through the image, I will explain later on. And there was flow in it also. Long tubular structure with flow. And the flow was bizarre with mixing of blood and everything, means high turbulence blood flow. Here you can see we have a technique where one half of the screen can show you the Doppler image and other grayscale images. So you can see this tubular structure was in midline and draining somewhat posteriorly in the confluence of sinus and with a turbulence of blood flow. You can see this bizarre mix of blood shows that blood flow velocity is very high. So turbulence of blood flow. Then there was cardiomegaly. So the long tubular structure with turbulence of blood flow and cardiomegaly. We had a diagnosis in our mind. I'll not tell you, I want you to see the cardiac fetal MRI images. These are the blood flow. You can see high, very, very low resistance flow. Why? Because this is the systolic peak and this is the diastolic peak. So diastolic peak is as equal to systolic peak. That means it is a very high diastolic flow kind of blood flow. And that signifies this kind of flow we get in artery basically. So we call it arterialization of vein. So you can see these are the blood flow, and in this artery we get arterial flow which we labeled as feeding artery because there was an arterial flow also inside this tubular structure. So these are the flow, I will skip. Now we did fetal MRI to understand what additional information we can get. So this is the fetal MRI structure images. Now what you can see, there is a long tubular structure in the midline and draining posteriorly into superior sagittal sinus through straight sinus. This is the midline tubular structure and this is the draining sinus, and this what you will see is a straight sinus that is persisted only in the in the fetus.
Vein of Galen?
Yeah. Vein of Galen malformation, correct. And on the axial images, you can see this is the midline tubular structure that we saw on ultrasound, and it is draining posteriorly into superior sagittal sinus, and this is called straight sinus. The straight sinus disappears after the birth. And this is the coronal image. We try to take images in both the axial, sagittal and coronal plane because MRI is all about taking the images in all the three planes. So, and of course, on MRI also you can see cardiomegaly. Cardiomegaly is of a rough idea. It should not occupy more than 1/3 of the circumference of the thorax. You can see it is occupying more than 1/3. So roughly you can see if it is occupying 50% of the area, then it's a cardiomegaly. So what we saw, evidence of well-demarcated tubular shaped flow void represented in large midline median prosencephalic vein of Markowski. This one. This is a median prosencephalic vein of Markowski and adjacent in large falcine sinus. This sinus is draining into the superior sagittal sinus via a structure called straight sinus here. So the diagnosis, as Dr. pointed out, this is a vein of Galen malformation. Of course, the diagnosis was clear on sonography, no doubt, but on MRI, we came to know that there was a draining straight sinus which disappears after birth and draining into the superior sagittal sinus. So we got the additional information. What was the another benefit? Now, in this kind of case, sometimes ischemia happens in the rest of the brain structure because of the blood flow. So we ruled out that by doing fetal MRI, there is no other abnormality, because I don't think we about this kind of baby, if there is vein of Mullen formation, I don't know exact treatment.
After 28 weeks you have diagnosed, so anyway after 28, 30.
We can't do that, I understand, that is PCP and MTP rule is there, but as a whole if we...
So but needed for prognosis, sir is there?
Exactly, so that is what I...
Correct.
That's where you get Fox as deletion. You see the big heart, murmur, in failure, and then you are completely Fox if you did not have the possibility of the vein of Galen.
Correct, that is very important. Yes.
Yeah. So suppose vein of Galen malformation is diagnosed, So now in an ultrasound report also, what I would be very interested to know is the signs of congestive cardiac failure, number one. Number two, if there is a hydrocephalus. Okay. These are the two prognosticating factor. Of course, there's the flow across the vessel. So 1/3 of the children would have a very high outflow fistula, leading to a congestive cardiac failure antenatally, having high drops, and they don't make it. Their prognosis is very bad. Then 1/3, they are delivered and they succumb within 48 hours, in spite of best of the efforts. So the 1/3 that they survive have a low outflow fistula, leading to a low congestive cardiac failure, probably medically managed, and then we can treat them. So, no, I have just put a reservoir for that child. Because the child had hydrocephalus. Now, etiology of hydrocephalus is also slightly funny. One is that because of the mass effect that happens over the aqueduct leading to an obstructive hydrocephalus, but more than that, because there is a high venous pressure in the sagittal sinus, backflow, leading to an abnormal absorptive problem. So you can have a ventricle size that is almost normal, but a very high pressure. And the risk of hitting those ventricles is that the moment you decompensate the ventricle, the vein of Galen ruptures by itself.
And so after putting those, as I said, prognosis of your patients?
Prognosis, again, the same thing, see, 1/3, they would not make it also.
No, sir, the patients who have survived.
Correct. So now again, it is like mild, moderate, severe, I have 3 children. There, the vein of Galen got thrombosed spontaneously. No intervention was required. 2 of the antenatal cases, we just put in a shunt, we bought time, the vein of Galen was embolized by endovascular surgeon, and they are doing good. So the primary etiology or primary prognosticating factor is the fistula outflow. And if the child can survive till 6 months, 4 months, that is the best. So if not, then they have a bad prognosis.
You embolize the vein of Galen?
Yes, sir.
So one more message, because we wanted to have this perinatologist, hydrops cases. So hydrops has so many etiologies, and unless we have a confirmed diagnosis of previous hydrops in the previous pregnancy or a child, we sometimes, hydrops either chromosomal abnormalities or Turner, but unless we have a good workup in this case, some pointers where we know that it can be non-genetic or some malformation, we are really not able to help in the next pregnancy.
So the vein of Galen malformation is misnomer. Nomenclature is quite imprecise, as this anomaly does not involve the great cerebral vein of Galen, but it involves its precursor called median prosencephalic vein of Merkovsky. In the course of normal development of intracranial vasculature, this vein undergoes involution and is replaced by middle cerebral vein. The proximal fragment completely vanishes and the distal part is transformed into vein of Galen. So it's a misnomer. The abnormality basically involves the median prosencephalic vein of Merkovsky. Now, moreover, it is also possible that a structure typical for early embryonic development, such as falcine sinus, become preserved, which may result in arresting the development of other sinus, like the straight sinus. So, in this case, what you will find, the other venous sinuses of brain might be hypoplastic because of the persistence of the embryonic structure called falcine sinus, which happened in this case. Now, differential diagnosis theoretically are AV fistula, complex development venous anomaly, and giant aneurysm. Because whenever in medical field we are always have to deal with differentials. In this case, it was vein of Galen, but if there is confusion, if it is not a clear case of vein of Galen malformation, we should keep all this in our mind: dural AV fistula, complex development venous anomaly, and giant aneurysm. Our case was a clear case, but again I will emphasize, fetal MRI helped us in getting some additional information in this case. Regarding prognosis, as I told you already. Case number 3. A 27-week fetus with disproportionate prominence of occipital horn of lateral ventricle, suggestive of colpocephaly. In this case also, ultrasound made the diagnosis, but again I will emphasize the same thing, what additional we got from MRI. USG images. USG images, you can see colpocephaly, criteria more than 10 mm was there. This is the coronal images, these are the axial images. Now, we did the fetal MRI. On fetal MRI also you can see, this is the colpocephaly, abnormally dilated occipital horn. What additionally, you are able to find something additional in this scan? I know you are not very much aware about the sequences of fetal MRI, but some radiologists are also here. if anyone can point out what additional information you can get from these images in addition to the disproportionate enlargement of occipital horn.
Posterior brain is smooth.
Actually, during the development, it happens. You can say, but this kind of sulcation comes as the fetus grows. Of course, you can see this undulation is little bit. Yeah, you can see this midline structure is completely missing.
Yes.
Yeah, so this is a case where corpus callosum is not at all, and colpocephaly is associated with corpus callosum. Agenesis. So this is the coronal image. Now you can see the third ventricle is very high riding and it is communicating with interhemispheric fissure. So the diagnosis was very much clear that it was a corpus callosal anomaly, and then there is the high riding third ventricle and communicating with interventricular hemisphere. This is the sagittal classical images that I want to show you. Here you can see there is no corpus callosum. So by fetal MRI also you are able to diagnose that it is a corpus callosal anomaly, and lot of additional findings are there with this entity. So those are ruled out. So I will just summarize this image. Here you can see this is the normal for comparison. This is the normal image of fetal MRI. When we do the fetal MRI of face, you will see the corpus callosum. Here you can see the midline structure is completely gone and the high riding third ventricle is communicating with the interhemispheric fissure. So, and we see this as a colpocephaly with parallelization of lateral ventricle, because lateral ventricles are now parallel to each other because the midline structure is not there. And this is the ultrasound image. So this is the combined image. You can see this is the ultrasound finding. We were suspecting corpus callosum in ultrasound also, because in high section also we were unable to see that corpus callosum-like structure. Frankly, I was able to find out. But then fetal MRI precisely gave the exact detail of the lesion. And in addition, we were sure that there was no abnormality of the spine, no other abnormality associated with that. And the one additional information that I would like to emphasize is that here you can see there is some undulation of the outer side of hemisphere. So this is also abnormal sulcation. I compared it with the fetus of this age. This kind of abnormal undulation is not there in normal fetus. So this is also the one additional information that we got from fetal MRI. Now, so the diagnosis is very clear: corpus callosum agenesis. So the findings I have explained you, and this is the finding that was very clear in ultrasound. There is abnormal sulcal morphology characterized by multiple abnormal cortical enfoldings, more marked in the right hemisphere, showing left salvo-sylvian fissure. The lateral ventricle is dysplastic with multiple undulation along its margin. So this information was possible only on fetal MRI, where the undulation, abnormal sulcation, everything was clear. So that we have to understand that we do fetal MRI to get additional information and whatever detail we can get. And rest of the structure like pons cerebellar was normal. Now coming to the last case,
diagnosis.
It was corpus callosum agenesis and colpocephaly. That was.
And the baby was born.
He was born, but then again,
male or female?
Yeah, baby was not delivered in our hospital.
Male or female? You don't know.
Yeah, because she was from, I think, Uran or some other. Because see now, this kind of case will not come here. These are the cases now which comes from, some kind of village side.
There is a syndrome called Icardi.
Yeah.
There is a syndrome called Icardi.
Yeah.
Exclusively in female.
Yes.
Get this.
Correct.
And there, I don't know what associated MRI findings are there, but I would have thought of an Icardi when you showed me that.
Correct.
If it was a female, I would have said this is an Icardi.
Icardi syndrome.
Huh? Mike.
So actually, this kind of all cases that comes to our hospital are from periphery, late diagnosis. Then they come to our hospital for further workup. Because if we do the follow up from NT scan to second trimester, there is rarely a case where we miss a finding in NT scan and then we get a finding in second trimester. This scenario is everywhere in Mumbai. Once the NT scan and proper follow up is done, you won't find abnormality in second trimester. The change I have seen over the 18 years. Previously, there used used to be, direct scan as an anomaly scan. There was no awareness about anti-scan and all those genetic things that we are doing.
So such cases come to us perinatally when it is about to be delivered. What we can do with this child? Whether we should admit this in NICU, whether we should spend on this child, how we handle. So pediatricians either send or obstetricians to us as geneticists that partial callosal, what would be the prognosis, whether we should put this child in NICU or whether we should deliver in a setup where we don't have to spend, whether we are ready to do genetic diagnosis, but what would be the prognosis of a child. So that perinatally such queries come.
We see corpus callosal agenesis in adult patients also because
yes, so some of the patients, some percent cases.
60% of cases with ACC will have mental development
delay, but many of the cases will have good mental outcomes. So that is yes.
So it is unpredictable. If they
partial callosal agenesis, many of the cases can have normal outcomes.
Karyotype or microarray, even single gene disorders are there. Chromosomal disorders, 10% will be there, another 15%.
And we have seen, madam, few children who have mild developmental delay. So they are not that partial callosal agenesis has to have a very bad prognosis. Series of patients,
and we diagnose partial corpus callosal agenesis in symptomatic patient also. So that is common. There will be a symptomatic partial corpus callosal agenesis, then some lipoma will be associated with that. If you ask the patient history, normal development, everything is fine. So those kind of cases come up in adults.
No, the thing is that, see, it's called observer's bias. So if you talk to a pediatric neurologist with corpus callosum agenesis, he would say that, he or she would say that they have a bad prognosis. Because most of the delayed milestone, people, they land up with that. If you ask a neurosurgeon, if I do a child for a head injury or just headache or some evaluation, and then I find that there is just an incidental finding and the child is healthy and hearty. So there is a bias in the things. But yes, whenever the one important point that Vipin has told is once you see one intracranial abnormality, you have to look out for all the other abnormalities. That's the rule of thumb.
Okay.
The moment we saw the corpus cephali, the thing is that we have to see other all midline abnormalities. A radiologist would take an effort and time to rule out that. And then second thing for the corpus callosum is whether it's a partial or complete.
And then serial evaluation by pediatricians and us growth development is needed, whether really neurological developmental delay will develop in this child or not.
Only after 6 months.
It is overwhelmingly saying that 60 to 70%.
But still have, so genetic investigations would be needed.
So many patients,
step by step.
many parents do not want to take that risk.
Yes, so we will do the investigations.
Just to give information, Leonardo da Vinci, we all know, a genius, he had agenesis of corpus callosum. It has been recorded.
Coming up to my last case, 21 week fetus with finding of retrocerebral cystic structure that communicated with a prominent fourth ventricle on sonography. On sonography, there was a cystic structure here, and the cisterna magna was separate from that. This is a cystic structure, this is cisterna magna. This one. Again, we have our diagnosis in our mind, but we did fetal MRI to see, as I told you, once you get any abnormality in brain, then you have to rule out any other abnormality. On ultrasound, except that cystic structure, nothing else was there. Then nothing significant was there, so we went ahead with the fetal MRI. In fetal MRI, you can see there is cystic structure in infravermian portion, this one. First I'll show you the images, then I'll tell the diagnosis, and then you can see the normal ventricle, everything was normal. This is the coronal images. I will just scroll through it. The spine and all the structures were normal, nothing significant. And this is the classical sagittal images. Here you can see this cystic structure openly communicating in fourth ventricle, and this is the infravermian cyst. So what could be the diagnosis? Anyone? There is an infravermian cyst communicating with the fourth ventricle, and it is not communicating with cisterna magna. There is upward displacement of vermin. There is no vermin hypoplasia or rotation, no evidence of hydrocephalus. The cerebral parenchyma is absolutely normal. That's what we concluded after doing that fetal MRI and sonography. So this is the finding. The infravermian cyst communicating with fourth ventricle, the cisterna magna was posterior, there is upward displacement of vermis, no vermian hypoplasia. This is very important negative finding. There is no vermian hypoplasia. The cerebral parenchyma is normal. So what I think the negative finding is as important as the positive finding. Because when you say that these are important, these things are normal, then you are ruling out a lot of things. Because with this kind of finding, of course, the DD will flash in your mind. So you need to give the negative findings. That's why I am emphasizing on the negative point. Anyone? Radiologists? My radiologist colleagues?
We had a detailed discussion today. Somebody has to talk about it. Yeah. Brainstem temporal angle, brainstem vermian angle. Brainstem vermian angle and brainstem temporal angle. So it's a pouch of plexus.
Yeah, correct. Pouch of black, yeah, that is the diagnosis. The diagnosis is black pouch cyst. So what is the etiology is that there is failure of regression of foramen of meninge in this case. And this is because of that we got black pouch cyst. So this is the image of sagittal, coronal and axial images. Now prevalence is 1 in 1,000 births. It is an isolated finding, mainly seen in trisomy 21. Up to 5% of cases, but usually in the presence of other suggestive markers. So if you get black pouch cyst, then you should consider that case might be of trisomy 21, then further workup can be done by madam, because I think I am correct 5% of cases with trisomy 21. Because I don't be as a radiological data, but I can. So black pouch cyst is, of course, there was no other abnormal finding. Then we have to be careful that if you get some testing done, then this case has to be in my mind. 5% of case trisomy 21 can have this kind of finding. Now I told you usually black pouch cyst is also known as rudimentary fourth ventricle telacordy, is a normal transient structure during embryologic development, which regresses usually by 12th week of gestation when it starts fenestration to form foramen of meninge. So when foramen of meninge regresses by 12 weeks when fenestration happens. But when fenestration will not happen, then this structure will fenestre as black pouch cyst. Simple pathophysiology. Ultrasound में क्या मिलेगा? Expansion of fourth ventricle into cisterna magna, resulting in a unilocular structure called keyhole sign. Vermis will be normal and cisterna magna will be normal. So this is the keyhole sign I was talking about, this one. Now at corollary, we also get keyhole sign in one more abnormality in posterior urethral bulb. So keyhole sign we see in black pouch cyst, and also in case of posterior urethral bulb, we will see the dilatation of the urinary bladder. This is just a corollary. Now, MRI finding is detailed. I told you infravermian cysts that communicate with fourth ventricle. These are the detailed ones. No vermian hypoplasia, important negative finding, elevation of tentorial and etc. Follow-up ultrasound scan every 4 weeks to monitor the size of the cyst, and possible compression resulting in ventriculomegaly. So this cyst can lead to ventriculomegaly. So we should suggest a follow-up 4 weekly. Spontaneous resolution occurs by 24 to 26 weeks in 50% of cases. Sometimes this disappears by the third trimester due to late fenestration. So in follow-up case, you can see that cystic structure is disappearing, then it's fine. Otherwise, you can recommend fetal MRI for the reason I told you, to find any other abnormality or not. Treatment, Sir has explained, neurodevelopment is good in 90% of cases, mild impairment in 10%. A small risk of postnatal hydrocephalus is there. And then endoscopic third ventriculostomy, I am not going to treatment part. Differential diagnosis is important. What is the differential diagnosis? Every time I told you there was no vermian hypoplasia. Why was I emphasizing on that? Because you are ruling out Dandy Walker. That was the importance of doing fetal MRI, to tell that there is no vermian hypoplasia, so we are ruling out Dandy Walker. Arachnoid cyst is again another disease. So this black pouch cyst and Dandy Walker malformation can cause a mass effect on cerebellum and hydrocephalus compared with other conditions. And an associated vermian hypoplasia, high position of trochlear hairfly and absence of vascular help in differentiating Dandy Walker from black pouch cyst. So if there is vermian hypoplasia, high position of trochlear hairfly and absence of vascular hairfly, then you should suspect Dandy Walker malformation, but for that you need to do fetal MRI. So I have shown you 4 cases in which I emphasize the importance of fetal MRI. Now, just 2-3 slides about fetal MRI. We are doing fetal MRI in our hospital. We have Philips engineered 3T MRI machine. Patient preparation, I told you, it is a technical thing. Mother should be 4-hour fasting. The bladder should be partially empty. And comfortable position to the mother is very important. I do the counseling of the mother for at least 10-15 minutes because I tell mother to be quiet, to relax. Otherwise, if mother will be anxious, the baby will keep on moving. So 15-minute counseling is very important. And believe me, when the mother understands the procedure, she is cool, calm, the baby movement substantially decreases. So as a nature, andar le le, fetal MRI karna hai. No, it's a horrible situation. The baby will come right, left, and technician will be doing multiple scans. We take 25-30 scans, out of which 3-4 scans are of our use. So patient counseling is very important. Now, left lateral decupitated position we can do to avoid the compression of vena cava, and then in many cases we put the feet first, not the head first, to avoid the claustrophobia. And you can ask the partner to be in the room to feel her comfortable, and adequate counseling of the patient, and maternal sedation we never use. We give passive nasal cannulation sometimes so that it also decreases the movement. If we give passive nasal cannulation, the fetal movement decreases. The whole idea is to decrease the fetal movement, which is not under our control. So good counseling, good position, a good MRI console room where partner can be there, and this passive nasal cannulation is needed. Now biosafety, absolutely second trimester, third trimester you can do fetal MRI, there is no problem. But imaging in the first trimester is not recommended because ACR recommends imaging after 18 weeks as the effect of static magnetic field, radio frequency pulses are rapidly changing and are not yet be defined prior to 18 weeks. So we should avoid in the first trimester as much as possible, and believe me, first trimester it is very difficult to do fetal MRI. The structure is so small and you cannot precisely tell. So ultrasound is an investigation of trial, but don't send the patient in first trimester unless risk-benefit ratio overweighs each other. Another thing, just I want to emphasize, I get lot of cases now. Anomalies can we don't do fetal MRI because I told NT-scan may sub we diagnose and we abort the baby if there is some abnormality. But we are getting fetal MRI basically now I want to rule out placenta accreta. Placenta accreta. But the problem is that we are getting the scan in third trimester. But for placenta accreta, you need to send the baby between 24 to 28 weeks. But 90% of the fetal MRI for placenta accreta comes in the third trimester. It's a horrible situation for us. So this is some information that I want to pass on to every one of you, that if you want to diagnose placenta accreta, please send the baby between 24 to 28 weeks. Don't send in the third trimester. It's very difficult to diagnose. So that is all about, and just one point I want to emphasize, we have a software called compressed sense in our hospital. Compressed sense. What is the significance of this compressed sense? It decreases the scan time by 50% without compromising the quality. The scan which is done in 5 minutes is done in 2.5 minutes without compromising the quality. The result of which is that with compressed sense technique, we are doing H sequence in just 60 seconds that we used to do in 2 minutes. And the scan with T2 is done in 1 minute. So you can see in 60 seconds we run a sequence because of this new technique called compressed sense. So in fetal MRI it has helped us because further decreased the time period by 50%. The scan that used to take 2 minutes now takes 60 seconds. So we are doing fetal MRI in a dedicated way. You can send the patient to us. Of course it is a technical challenge, but we try our best.
You have 3 Tesla?
Yeah, 3 Tesla. Thus one more corollary, in US and UK they prefer 1.5 Tesla. This is another gray area that I would like to highlight. They think that 1.5 Tesla is better for fetal MRI. But you know, India has... But India mein kya ho gaya na, 3 Tesla came na, everyone is writing 3 Tesla. Believe me, for spine you don't need 3 Tesla unless you have some kind of tractography, high-end test for which CT is needed. But India mein once CT will come, 1.5 Tesla will become obsolete. 1.5 Tesla is very good equipment, but everyone had penchant for writing 3 Tesla, fetal MRI mein chalu kar diya hai. But 1.5 Tesla is ideal.
Yeah, it's very difficult to convert the 3 Tesla to 1.5 Tesla norms also. Because all the work which has been published, all these years has been on 1.5 Tesla.
Correct.
Now you suddenly get me a 3 Tesla. Then I have to convert my T2 star or my R2 star or whatever value I get into a...
Correct.
It's very confusing.
Actually, sir, 7 Tesla is also there, and they are doing wonderful work in cerebellar and other detailed structure, but they are in research phase. Now, 3 Tesla, we have to understand, it has some kind of special need that we do 3 Tesla, but here in Mumbai and India, you know, the vendor will come and they will themselves say that 3 Tesla is better than 1.5 Tesla for all the scan. But this is not a correct information they are passing on. So I thank you for your...
Thank you, Dr. Vipin, for excellent images and your spotters. Any questions? We have Dr. Bindu. Dr. Bindu, when we get, he says that black pot cyst and coral plexus cyst, we are anyway doing NIPT. So a small percentage of patients who have trisomy 21 and all, we are already doing NIPT. So non-invasive prenatal testing, as we said. Where normal variations may be having some risk of aneuploidies, we are doing NIPT here.
Yeah,
so
that is very important, yeah.
So we will have, Madam, if you can felicitate Dr. Vipin for his excellent talk. Dr. Vipin, if you can stay for cases. We'll have a quick 3 cases from, one is from Apollo Hospital, one is from D.Y. Patil Hospital, and one is from Dr. Mohiti's Hospital, Patwari. Thank you, Dr. Vipin. So we can immediately.
So we'll begin with the panel discussions. I'd like to invite Dr. Vishakha. She's the clinical associate here at Institute of Obstetrics and Gynaecology, working with Dr. Bindu.
Since we are getting ready for the panel, in NIPT I have missed out on one slide which I did mention, which I actually reminded, that in case if you get sex chromosomal, you will get some reports where there is a sex chromosomal aneuploidy cannot be given. In such cases, what we have to do is, we have to do maternal blood. If mother is having the sex chromosomal abnormality, so our patient had trisomy X, the lady, and there was no sex chromosomal result given on NIPT. I'd forgotten to add in this slide. This time might I say.
Dr. Bindu, who is head of the unit, will be moderating. Dr. Bindu will be moderating or will be from there?
आहे का त्याच्यात?
डॉक्टर कोण कोण आहेत?
Sorry for the delay, but we'll start inviting panelists. If we will start simultaneously opening the slides. We have Dr. Satish. Dr. Satish is a senior pediatrician and president currently of Navi Mumbai IIP with special interest in pediatric critical care and infectious diseases, a consultant at Sanvi Hospital, Kharghar. Dr. Satish, we welcome you. Then we have Dr. Chintan, who is a consultant radiologist at Apollo Hospitals. I don't know why it's not opening, Dr. Chintan. But we always take his opinion, especially for pediatric and genetic cases. We have Dr. Om Prakash, who is a consultant pediatrician and NICU in charge here at Apollo Hospitals. And Vishakha is,
and Dr. Snehal ma'am, who will be... You come. Yes. Hello everybody. Myself Dr. Vishakha Yevle. I am a clinical associate with Dr. Bindu ma'am. First of all, I'd like to say that today's morning sessions of Dr. Hema ma'am and Dr. Merchant sir were very delightful and, very inspiring for us. I hope in coming years we also, go through all these phases. Okay, so we'll be starting our series. So we'll be discussing 2 cases today and its relevance to pediatrician, geneticists, as well as the obstetricians and how this multidisciplinary actions can be taken. Okay. So the first case, she was a 25-year-old lady, gravida to abortion 1. She came to us at 7 to 8 weeks of gestation. The typical family history was of that the patient's 2 out of the 3 brothers were having Wilson's disease, and one of the brothers succumbed to the same at age 15. The past medical and surgical history was not significant. The first abortion was terminated at 18 weeks in view of multiple anomalies. There was depressed nasal bridge, protruding upper lip, micrognathia, lemon-shaped fetal head, and the stomach bubble was also not visualized, esophageal atresia. The NT scan which was done for that fetus was done at 11.3 weeks, which was suggestive of the NT to be 1.1 mm and the CRL to be 48.9 mm. This fetus, when terminated, was not subjected to any genetic testing. So in view of such abnormal anomaly, so what invasive, non-invasive test can be done for the fetus? So I think Chintan sir can say, already we have got a great lecture from Vipin sir and Biyane sir regarding fetal MRI and fetal neurosonograms. So can you please emphasize on it?
Yeah. So a detailed anomaly scan we would prefer before 20 weeks, where we do the detailed neurology examination, lemon-shaped skull and lemon-shaped skull. Then you mentioned there was esophageal atresia and the stomach bubble was absent. So all these features, raise possibility of Downs and this. So a dedicated then workup would be required with the other markers and all. And if the patient is delivered, then immediately post perinatal period, we can do a fetal 2D echo also, because that is more superior in picking up the cardiac anomalies, if any.
Okay, sir. So, sir, in this specific case, will fetal neurosonogram or fetal MRI help?
Yes. If as Dr. Vipin said, the role of fetal MR is now more of problem solving, because anomalies can pick up everything. If we are picking up anomalies in the brain and we are suspecting it's a systemic, multi-system disorder, then fetal MR would help picking up some things which we may miss. But it's more of a problem solving. So 90-95% of the work will be done by the anomaly scan.
Okay.
So that will only pick up be it cardiac issues or the neurological issues. It will be picked up well on the anomaly scan.
Okay. Thank you, sir. So, Snail ma'am, this is for you. The importance of genetic testing in the fetal anomalies immediately after termination. So, what is...
So, as Dr. Madhvi had also asked, that we have to have an eye in every specialty for any severe disease, be it in obstetrics, pediatrics, adults, where you suspect severe disease, abnormal things, suspect genetics, please store DNA. So, if you are either send karyotype and store DNA, this fetus was not investigated. That is why we put that question that many of the institutes, fetal autopsy is not available. So, fetal MRI, fetal neurosonogram, fetal X-rays, this is type of non-invasive autopsy which helps us to gather information when we go ahead with genetic investigation. So, at least store the samples even if you are terminating the pregnancies and evaluate them later. That we are now routinely doing at Apollo Hospital. So, that should be the practice, I think, termination of pregnancies which are affected.
So this will be one of the, I think, take-home messages for today, that, storage of fetal DNA as well as, if any younger patients or
and fetal
patients.
autopsy not available, gather information from non-invasive investigations for planning next pregnancy, which will be helpful.
I'll just add to that fetal MR, in case of many patients want to avoid an autopsy, it is an option of doing a MRI post-mortem. It can be done about 1 to 7 days post-death, and we do pick up something, especially the neurological problems. Most of them are picked up on the MRI, may not require an autopsy.
So yes, so once we terminate the pregnancy, we can take that fetus or product of conception and do MRI. If it is not to be done antenatally and parents want to terminate, that is what Dr. Chintan is saying, that fetal X-ray and MRI can be done afterwards also where fetal autopsy is not available.
So cost is one factor whenever we think of genetic test.
Yes.
But if you think of DNA storage, it is very, very cheap and cost effective. Hardly some 1,500, 2,000 rupees the cost of storage of DNA. And see, this is stored for a good long time. So may not be parents are immediately willing for doing the test at that given point of time, considering the subsequently also whenever they...
There is initially we did not have any opportunity to do that, because once the time is lost, we lost the diagnosis. Nowadays it is available, so it should be used, and this will be like a boon to diagnose the rare disease also.
So true. So anyone can take up this next question, Satish sir or Om Prakash sir. What is the definitive diagnosis for Wilson's? Like, is it biochemical or has a genetic makeup also? So how to do it?
Yeah, initially we need to take the detailed history, then presentation, the age of onset basically. So initially there will be a presentation more of a liver involvement, then there is a neurological involvement, or sometimes there is a combination also. And if you want to prove it now, the biochemistry is definitely the liver biopsy, the content of copper, but with the evidence of genetic test, we should go for that, and we should make the complete diagnosis. So that even the last time one patient, the treatment also depends upon the genetic mutation, the myoma discussed, and that will be useful for our management also.
From ISABGAN, there are now very standardized guidelines as far as coming to the diagnosis of Wilson's, as Sir rightly said. So there are three things that they look. First is clinical and biochemical. So clinical is your signs of liver dysfunction and neurological signs symptoms that some patient may develop. In the same part, biochemical is signs of liver dysfunction, your ceruloplasmin level, copper, urinary copper levels. That is clinical and biochemical. And then next is genetic is coming up in a significant way. See, we are trying to do things as much non-invasively as possible. So if someone has got one mutation with clinical sign symptoms, that is confirmed diagnosis. If there are no clinical sign symptoms, if there is a family history like this, and if you have got 2 mutations, then again it is a confirmed diagnosis. And the third component is the biopsy part. The liver biopsy, what we used to do it earlier before the genetic testing, that is going downhill because we want to do more non-invasively, and they are quite confirmatory. If you have got a genetic diagnosis with 2 mutations without any sign symptoms with family history, I don't think we need to go for a liver biopsy for that situation. So this is very helpful for us. Genetics is coming in a good way in terms of any conditions, anything unusual with a background family history, you should always think of genetic component.
So here two different things was there, right? First pregnancy, completely different abnormalities, and brothers with Wilson disease. So 2 different things, and we don't have answers, both looking genetics, so definitely diagnosis is important. If you have pedigree.
Yes. So this was what we referred this patient to Dr. Snehal ma'am. She'll explain this pedigree better.
So in the pedigree, second, the arrow is the current pregnancy, 7 to 8 weeks, the mother came to us. First pregnancy, as Vishakha has said, that had multiple abnormalities, and 2 brothers, one had died of Wilson disease, and second is still alive. So we got the sample from another state of that brother. We diagnosed, we made a genetic diagnosis. Now pickup is available. We asked patients to take, home sample pickup is available. So we picked up sample of the brother, did a Wilson disease diagnosis genetically. So mother can be carrier because Wilson disease is autosomal recessive inheritance. So we offered carrier testing of the mother and carrier testing of the father. So I would like to add here that carrier testing of the mother they opted for, but they didn't want to do carrier testing of the father because they said that our one brother is alive and Wilson disease is treatable. So Dr. Satish and Dr. Om Prakash will add that Wilson disease is treatable disease. So for treatable disease, whether genetic diagnosis is advised or not.
So see, genetic diagnosis is required. That is first thing that all of us need to understand. The second part of making after the genetic diagnosis, what is your action? If it is a treatable conditions, you are not going to suggest the parents for termination of the pregnancy. If it is an untreatable condition where things are black and white clear, the prognosis is not good, then yes, then we can give an option to them that what next can be done. That is up to them what they want, because we have seen some parents where there is antenatal diagnosis is there well in time before like second trimester, but parents wanted to continue the pregnancy. So we have to give due respect to them and then help them to guide further in terms of whatever the care the baby is required. That is what I want to make clear to all of you. Now, whether Wilson's disease or treatable, not treatable, that will be depend on the condition of the child at the time of presentation. If Wilson's disease is causing severe neurological issues, I will say it is not a treatable condition by doing liver transplantation. That is very difficult to comment who is going into cirrhosis and liver failure or acute liver failure and who is going to develop a neurological symptom. So that is very difficult to comment antenatally or just by doing the genetic screening. So the clinical presentation at that point of time will decide what is the situation, treatable or non-treatable. But otherwise, from general public point of view, Wilson's disease is diagnosed by different parameters, the clinical, lab parameters, and the genetic parameters, and there is a treatment available for Wilson's disease. So it is not a situation of termination of pregnancy based on diagnosis of Wilson's disease.
Yeah, so here actually the family chose to have only diagnosis of chromosomal abnormalities. They refused to do carrier screening and testing for Wilson disease, and that should be respected. So counseling is sometimes may be complicated because Indian Gastroenterology and Hepatology Society says that prenatal diagnosis of Wilson disease is not mandatory. So you have to discuss that also with the family, and the family refused. So the message is that there can be multiple issues in counseling and testings available. We have microdeletion duplication chromosomal abnormality which can be screened by NIPT, as madam has also shown in her presentation, and we have multiple testing like karyotype on invasive testing, NIPT, microarray which can be chromosomal abnormality can be ruled out, and for Wilson disease we need to do sequencing. So there are different tests which need to be discussed with the parents, different costs are involved, some may be refused by the parents completely, and that is respected in counseling.
So in our case, the affected brother was tested, and he came to be ATP7B homozygous pathogen variant in exon 2. And as ma'am said that the couple was not interested in the prenatal testing for Wilson's disease for the baby. And so...
but they wanted to do chromosomal abnormality, so we did NIPT.
Yeah. So NIPT was done and that was normal. Om Prakash sir, I would like to ask you that if such a patient comes, like they have refused the prenatal screening, so in the postnatal monitoring and testing for Wilson's in this family, I would like you to comment upon it.
So here the family history is very important. Whenever we are looking in the background, it's just not the birth history, it should start retrospectively the family history. In this background, there is one child who is confirmed mutation is there. So this child clinically may present around 5 to 15 years based on the severity of the affection of the liver. So we don't want to wait for such a long time. Postnatally also, we are going to suggest to the parents that it is better to look for the genetic markers and confirm whether there is likely possibility of, this child being affected is there or not there. Unfortunately, again, parents didn't wish for doing their own screening also, because if both of them carrier, there is high chances that this child will be also having same situation, because there is one family history of homozygous variation is there. So we need to monitor this child, preferably get genetic screen done. As I said in the criteria laid down by the SIPGAN also, if you have got 2 mutations without any clinical sign symptoms, it is a confirmed diagnosis of Wilson's disease. But we need to monitor closely in terms of the liver dysfunction. We need to look clinically for the development of KF ring. But all these things are basically accumulation of copper, and this is going to take time. As I said, the presentation may be somewhere around 5 to 10 years also. So better to get done clinical, if before clinical symptoms, better to do a genetic testing. But if there is some clinical sign symptoms appear, then again we need to reinforce the parents. It's better like repeated counseling and bombarding them that it is important to do the test so that we can pick up early and treat early and prevent the complications. Because once neuropsychiatric complications are developed, then it becomes a bit irreversible situation to manage.
But pre-symptomatic testing in only few diseases where you can offer treatment. So pre-symptomatic testing is allowed in Wilson, where you can start treatment. Many other diseases in pediatrics, pre-symptomatic may not be allowed. So that has also be kept in mind.
So either pre-symptomatic treatment or else a rigorous follow-up for the baby in the coming few years. Chintan sir, so in such a case where the previous baby was also anomalous and with such a Wilson's disease history, so do we offer an early anomaly scan, and it should be done at what gestation? And in which cases do you recommend to do this?
Anomaly scans, usually we would prefer after 12 weeks because we can see all the organs, but as early as possible, even at 11 and 12 weeks now with transvaginal ultrasound, we do get to see the structures. But it's specific, like Wilson's, we won't be getting much on anomaly scan as such. Otherwise, cardiac specific issues, it's not very good to do an early anomaly scan. Still, the ideal time is around 16 to 18 weeks. So for this, I don't think there is any point of doing a very early scan.
Okay. So only first trimester screening, that is the most important, and followed by if in
trimester exactly for the aneuploidy and all the knuckle thickness and all that, the routine 11 to 14 weeks, which would be doing here.
Okay. I have a question here. You can go to the first slide. This anomaly were detected at 18 weeks. Was it possible in the first trimester screen any of these to get picked up or?
Yeah, so on the first trimester, out of these, it would be probably maybe the lemon-shaped fetal head and stomach bubble, but otherwise the depressed nasal bridge and micrognathia and all, the fetus is too small at that level to get it. So it may not be very comfortable one.
Okay, and does it fit into any?
This I would still think of maybe down trisomy 21 because there is esophageal atresia, depressed nasal bridge and everything. But surprisingly the NT was normal. But we have to check with the other markers in that sense. And we don't have any mention about the cardiac. So was there any cardiac defect or anything the report doesn't mention? That will even further strengthen the possibility of Downs.
Yes, in this era, now still with first trimester screening, I want Snehal to answer that. First trimester screening, again we have patients where even with a positive double screen and the NT is okay, but still they want to go for termination. However, we advise certain tests and all those, but then how to counsel them to go for the test for the... Abnormal anomaly scan? No, the first trimester screening.
First trimester abnormality, abnormal scans.
Even with the double marker, biochemical markers, they are not, so nowadays we are opting for the NIPT and
so they want to terminate, right?
Yes, they want to terminate. They don't want to go for further testing also. Still we come across some couple like that. And how to, like in those cases, when we are terminating, do the POC or the karyotyping can be stored.
With Purandari Madam and Vishalakshi, that sometimes patients are really not willing for testing, then do a karyotype or fish and store DNA for further investigations. So as early as they said that 8 weeks also, 9 weeks also, they are studying POCs with karyotypes, but they are also keeping the material where we can immediately extract DNA. So if you have a patient who is willing after MTP, take the sample, and if they are not at all willing for any investigation, just store DNA so that they can do the investigation. So not even karyotype they want to spend, just store the DNA. But DNA storage can be done at very minimal price. So that can be counseled well.
Yeah, this is a message for people like us, obstetricians.
Yeah, because most of the time MTP cost is very high. So patients say that we are anyway spending on MTPs. So we don't want to spend on investigation. So definitely we have to store the DNA. We are doing in many cases, Dr. Bindu, right? Yeah. So because patients in Apollo Hospital also cost is high, they don't want to do investigations. We store the DNA, ask them to come when they want to plan next pregnancy.
Thank you.
I just want to make a point here. Actually, there is a role of pre-symptomatic testing in Wilson disease. In fact, if the baby is known to be positive at birth, we can start oral zinc, which will stop the copper from accumulating. So if you give oral zinc right from birth in a homozygous baby, copper won't accumulate. The baby will not suffer from Wilson disease, even if he has a mutation.
Yes, pre-symptomatic.
Oral zinc lifelong.
Then I think evaluation will be needed, Dr. Satish.
What are the dose, sir? What are the dose?
I think that is best. Around 500 milligrams. Correct me if I'm wrong.
I don't know whether she's included the slide, but Wilson disease is also now coming up for NBS. They are trying in research, and some of the clinical trials are there that whether Wilson disease can be picked up in newborn screening by doing biomarkers. So that will soon come in.
Older children is around 500 milligram. I think in younger children maybe.
Because in India we have a high carrier rate of carrier status like thalassemia, of Wilson disease, or spinal muscular atrophy. So we are getting programs where we are doing NBS, which if comes into practice soon, we will be picking up Wilson disease very early. Even if there is, I mean, cases where there is no family history and high carrier rate.
Sporadic cases.
This we have discussed, we can skip Vishal.
So in our case, then the patient did deliver full-term vacuum delivery, female baby of 2.9 kg, and postnatal neonatal screening was offered. And so then, Satish sir, so how will such a follow-up? I think Om Prakash sir has already told that pre-symptomatic treatment maybe with zinc also can be offered, and then rigorous follow-up for the baby.
Yeah, definitely high risk, like antenatal high risk, we need to follow up regularly. Here the family history matters, and also we know about the condition. So if they are not willing for the test, at least in homozygous, as sir said, we can start treatment and we can monitor like basis of 6 monthly or yearly to find out the ceruloplasmin levels, and maybe if they are willing for the test in the further, then genetic counseling and testing can be done.
Our intention was asking Dr. Satish, because he is now heading NMIP, that at least even if patients are refusing testing, whether we can have some data from pediatricians of such patients who have refused testing, don't want to do testing, we want to store DNA and go ahead with some projects, some institutes who are doing for free. Not only for Wilson's, but many diseases our patients are not doing.
No, we can make a circular about the rare disease registry. That will be better, because the send each and every child from like people has to know which diseases we need to, I would say, registered and monitor. That will be better.
Yes.
We can take this call will be helping out.
So next case, patient was 39 years old, para 2 live 1, first section in 2013 in view of CPD, female baby. Second section was done in 2017, female baby had aortic stenosis diagnosed after birth. The baby was operated for balloon valvoplasty on day 3 and expired 12 hours after surgery. The ANC evaluation in terms of anti-scan, triple marker, anomaly scan and interval growth scans were absolutely normal. So, sir, when such a child, when such a couple with the history of aortic stenosis and such a bad prognosis for the baby comes, then should any genetic suspicion be in our mind for a congenital heart disease like this?
In this child, actually, the severe stenosis has led to this one, but ANC marker, but everything was normal. So, this is the sudden diagnosis even for the pediatrician also. But definitely, if there is a family history, also there is a previous now sibling history, we need to go for the genetic testing possible.
Yeah, so only aortic and stenosis, part of Williams syndrome we have to consider, and Williams syndrome may come with not only, there is a gene which is present in the Williams syndrome region, so which is autosomal dominant aortic stenosis. We had one family, mother had aortic stenosis, Masi had aortic stenosis, and the child had aortic stenosis, but there were no findings of Williams syndrome associated. So there is some single gene disorders associated with such diseases where you just have to, do genetic investigation for prognosis, because it may be taken as Williams syndrome and developmental delay, which is not the case. So yes, definitely sometimes genetic diagnosis, because and child has expired also, right, in NICU. So that is all the more important for if they want to have further pregnancy and also prognosis.
So it was not diagnosed antenatally here,
No,
isn't
sir.
it?
No.
It was not diagnosed antenatally, and postnatally child presented with signs symptoms of shock, and then
Correct.
we clinically and then 2D echo confirmed. So whenever there is such kind of situation, we should look for other associated thing. That is very important. They do have got associated hypoplastic left heart, because that is the major contributing factor, that your primary pathology of stenosis is taken care of, but your heart functioning is not great. So that is the reason they do land into consequences, and then they don't, manage from the cardiac function wise, and that may be the contributing factor. The child has got a bad prognosis. Second, whether we need to go for, relatively non-invasive in terms of balloon dilatation or a surgical intervention. That is second area where the cardiologist will be taking care of based on the severity of the critical stenosis, based on the gradient, how much it is in terms of the stenotic segment. And then third, now this child has got an aortic stenosis, couldn't be making, so what is the next in future? If the parents are planning for future pregnancies, if you see the normal population, there is 1% chance of having a baby with, congenital heart disease. But if a family background is this, then there are higher chances. If it is a sibling is there or first degree family relative is there, chances are like 3 to 5% chances more are there. So in subsequent pregnancies, we need to look for a 2D echo for the fetus, because here, as I asked, like specifically, it was not done. So it was diagnosed postnatally, and this can happen. In a NICU setting, we have seen babies who are discharged home and then subsequently coming maybe at the end of a week or 2 weeks when the duct starts closing. These are duct-dependent systemic circulation. So initially the patent ductus arteriosus is maintaining the systemic circulation, but as the duct gets smaller in size, they get compromised in their systemic circulation and they present with sudden shock or cyanosis, So a newborn screening looking at the saturation before discharge of the baby, that is very important. Look at the saturations in the right upper limb and right lower limb to see whether there is a difference in differential saturation is there. If the saturation difference of more than 5 is there, we repeat the screen again, and if it is showing the same finding, we should do a 2D echo screening for that baby, because there is a possibility of some cyanotic heart disease is there in that baby. So that is the next part that we should look for. Any discharges, make a policy that we do a screening for all babies. That is for the immediate, and then for the future pregnancies, we need to look for a fetal echo for subsequent pregnancies.
Vishaka, I need to fasten up. I think we have 2 cases.
Yes,
more.
just
We're
one
running
question.
out very late.
Yes. So, is this specific for aortic stenosis or for any congenital heart disease?
For all congenital heart disease, we can miss certain duct-dependent situations. So we should screen the babies before discharge. Generally, most of the discharge happen after like 48, 72 hours. So before discharge, you should have a documentation of saturations. Yes.
Thank you, sir. So, can aortic stenosis be detected antelatally, and at what age children.
Yes, in an anomaly scan, usually in the second trimester, and in general cardiac, the more delayed the better we see. But yes, in the second trimester anomaly scan, which we do at 14 to 18 weeks, before 20 weeks also, we look at the aortic valve, it's lesser than 5 millimeters or we are getting a high value more than 1.2 meter per second, it could suggest aortic stenosis. More specific finding would be a post-stenotic dilatation that suggests that this would be useful for a surgery. More thing is something we can pick up as Dr. Omprakash said, a fetal 2D echo will be more accurate, but something which is picked up on antenatal scan has to undergo a fetal 2D echo to get a very detailed imaging very early in the postnatal life.
Fetal 2D echo in terms of aortic stenosis is slightly tricky because the place where the duct is connected, there is a physiological narrowing is there. So sometimes people tend to miss that whether it is stenosis. So in that kind of situation, we need to do a postnatal confirmation. That is very important.
Okay, so depending upon
So
what measurements were given.
Post-stenotic dilatation is more specific.
Okay. So in such a case, then how can the recurrence risk be given for congenital heart disease? Yes. And this importance of genetic diagnosis. So this was how the 2D echo shows aortic stenosis.
Thank you, Vishakha.
Thank you so much.
Thank you, Vishakha, for this case, and Dr. Bindu. We will move on to next discussion.
Our next panel discussion is approach to non-immune high drops in NICU. And I would like to invite Dr. Parag Tamankar. He is a clinical geneticist with us, is consulting with us at Apollo. So please welcome. And I would like to invite Dr. Bindu. Yes, sir, please. Can we have another chair, please?
This case would be presented from D.Y. Patil Hospital by Krina. Sheetal, who is heading the NICU, is not well, so she has not come. Krina is third-year resident in pediatrics from D.Y. Patil Hospital. So the case has been prepared by Dr. Sheetal, NICU in charge, D.Y. Patil Hospital, and Dr. Krina, who is DR3 at D.Y. Patil Hospital. And we have panelists, Dr. Om Prakash, Dr. Satish, Dr. Parag, Dr. Chintan, and Dr. Bindu.
Good afternoon, everyone. So this is the approach to non-immune high drops in NICU. So this baby born to G4, P2, L2, A1 mother. Okay. A male child with birth weight of 2.8 kg with mother's blood group of A positive and no history of fever and rash in the mother. And there was one abortion is there because of the unwanted pregnancy. So the take-home message from this is a detailed history of abortion to be asked, especially during first trimester. Either it is a spontaneous or a medical termination of pregnancy, and family communication by obstetrician and pediatrician is crucial in these cases. So the history is, this baby was delivered by emergency LSCS in view of severe oligohydramnios with AFI of 1.5 centimeter. We got only 3 maternal scans. First as 8 weeks, it was a gestational sex scene with presence of cardiac activity. Second at 15 weeks, adequate amniotic fluid was there and fetal weight was 111 gram. And last was at 37 weeks at a time of delivery. It was suggestive of mild pleural effusion in fetal thorax, minimal ascites, minimal gallbladder wall edema, diffuse subcutaneous edema and more on the scalp and the faces, and mild cardiomegaly with minimal pericardial effusion. Questions?
Yeah, so because Dr. Sheetal is not here, I would like to ask Dr. Chintan and also add Dr. Bindu in this, that we have this fetus who has been lately detected as hydros fetalis, but severe oligohydramnios. So how do you deal with early oligohydramnios and late oligohydramnios and early hydrops and late hydrops when it comes to scans? Because this baby had directly 37-week scan and early in between it was not suspected. So whether you will suspect such abnormalities and look for specifically, and how do you follow up these patients, and how do you take this up for decision making during deliveries, because that is very important in NICUs, LSCS or normal delivery. So Dr. Bindu and then Dr. Chintan can add about hydrops and
So before the fetus reaching that stage of hydrops, we generally do 2D echo, sorry, not 2D echo, we do the obstetric ultrasound and also look at the flow in the umbilical veins and then ductus venosus flow. So that's a indirect marker if there is the fetus is having any cardiac depression. And we also measure the AFI volume. So if there's any oligohydramnios or something, which can pick up at an early stage. And so the hydrops fetalis is basically the fluid is getting in the third space. So any two fetal parameters where we are getting pericardial effusion, pleural effusion, generalized fetal edema or ascites. And all this in addition to if the patient is having polyhydramnios, all this is a picture of fetal hydrops that we diagnose on the ultrasound.
But in cases of severe oligohydramnios, sometimes it is very difficult to detect anomalies because of there is no amniotic fluid. Yes. And Dr. Bindu also would add. So how do you make a decision making in such case, Dr. Bindu, that how do you go ahead with delivery modalities in coordination with NICU and radiologist, and which things you will ask to do the investigations and counsel patients at NICU or LICS or normal delivery?
Yeah, here in this case, unfortunately, the patient didn't have any scans after, I think, 13 weeks ke baad, na? Though there was 15 weeks ke baad. There was no proper anomaly scan or even the 24-week scan. Nowadays, we are doing the 24-week scan to pick up late anomalies and there is no history of any infections, fever, rash, so that the infection part is rolled out. So here, regarding the whatever available this thing, communication with the patient. She has come to me at around 37 weeks. So I have to communicate to her like these are the things seen on that, and then she should meet because it should be a multidisciplinary approach. So the obstetrician with the neonatologist, the radiologist, and the patient should be delivered in a tertiary setup like that with a proper NICU. And regarding the patient monitoring with severe oligohydramnios, see, we have to see whether the baby is in distress or not. So if even with severe oligohydramnios, the AFI here is only 1.5 centimeters. So the problems during labor, or if she's going for natural labor, the problems of fetal distress are definitely going to happen. But if the AFI was a little bit around 4, then even we we do the Bishop scoring at that time, and all cases need not be delivered by LSCS. But here with 1.5 centimeter, I would be a little more skeptical about delivering her normally, and because in view of we can come across like anomalies which need dire emergency attention and all those. With the AFI 1.5 centimeter, the chances of normal delivery will not be considered much. But it was a 4 centimeter or something, we can take the chance of doing the Bishop's evaluation, and if cervix is good and all those, even we can, that obstetric indication for normal delivery can happen. We can then immediate handover to the NICU team can be there.
So we discussed not in oligohydramnios, but Dr. Chintan, that fetal 2D echo as late as in which cases where you see hydros fetus coming to a tertiary institute in a late gestation, and Dr. Om Prakash has said that fetal 2D echo helps in NICU management. So what as late as some information can be gathered on fetal 2D echo?
Even in the routine anomaly scan which we do in 16 to 20 weeks.
No, after, I mean coming in late gestation.
Even later, and also we whatever is done on the fetal 2D echo, we do a dedicated anomaly scan again at that age, that weeks of gestation. We look at the heart rate to pick up any arrhythmias, if there is any intracardiac lesion, or if there is any complex cardiac congenital defects. So these can be picked up, and then they could be the cause of the
and in cases of oligohydramnios, in such case,
oligohydramnios we specifically look for if there's any renal dysfunction, or again it could be cardiac issues. And if torch infection, anything else is there, then there's not much that we can pick up. But yes, the other major structural issues with the heart, kidney and all can be picked up. Even if it is oligohydramnios, we can do a dedicated scan and pick up the things, not an issue.
Generally, hydrops is associated with polyhydramnios.
So that is why I asked specifically that this case.
Oligo is there with hydrops, that means there is possibility of some renal issues. That is what we can think antenatally before the baby is delivered. That we should keep in mind.
So this baby cried immediately after birth but had a weak cry, so basic neonatal resuscitation was done and baby was shifted to an ICU in view of respiratory distresses. Examination finding on initial assessments where there was tachycardia, tachypnea, pulses were poorly felt, delayed CRT and cry tone activity was poor. So baby was intubated and kept on ventilator. Systemic examination, CNS was depressed, air entry was bilaterally reduced and per abdominal distension was there with hepatosplenomegaly. So this was the initial X-ray just after intubation in an ICU. Further course in NICU, we sent investigations. Inotropes were started in view of shock and severe metabolic acidosis. pH was 6.9 and BICAP was 7 with base axis of -23. Baby was kept NBM and prophylactic antibiotics were started. So to summarize this is a term AGA, antenatally detected at hydrops with no history of maternal infection, severe oligohydramnios, previous history of 1 first trimester abortion with respiratory distress, with shock with hepatosplenomegaly.
So Dr. Satish, I would just like to ask that this is a very severe case where you attend, if a pediatrician attends a delivery and finds something, that it would refer to a tertiary hospital. But isolated oligohydramnios or mild hydrops which is present in this child going into respiratory distress. So how do you manage and what would be your differential diagnosis in such cases which you would like to explain it to parents and go ahead with investigations?
So most likely pathology started little late in this case. So because if there is a metabolic or some genetic component also, it are presented with polyhydramnias or maybe a early hydrops. So this is late onset. So possibly if you think about the maybe 32, 34 weeks he started the problem. And second is when they know about the antenatal scan at 37 weeks is showing some signs of respiratory, neonatal problem, then definitely we need to deliver this case in tertiary care. Second, after that, during delivery also the resuscitation or measure as per the NRP guidelines. And third is the quick transfer to the NICU. In these cases, the possibility as a differential we need to keep, because as a non-immune hydrop, like what we used to have initially is immune hydrops because of RH isoimmunism. It is not there, or we rarely see now because of the, now I would say good antenatal care, frankly speaking, and now we are getting more of a non-immune. So non-immune also we get more commonly as a pediatrician we come across only two, either in cases of like cardiac anomalies or cardiac problems or hematological problems. So here either of two can be there because the hemoglobin is also low. So we'll think about that and then we'll investigate accordingly.
So next question would be Parag, that how to differentiate between genetic and non-genetic causes of respiratory distress with non-immune hydrops in this child, because this child is presented with respiratory distress, mild hydrops, oligohydramnios also. So whether it is related to per se baby's condition that the child, or whether you would like to go ahead and think of genetic causes.
Was there any, what was the hemoglobin of the baby you said? 6.9. Yeah, so it's quite low. So, and the bilirubin was, what was the bilirubin? So basically you need to see whether it is hyperplastic or hemolytic anemia. So hemolytic anemias can be one possibility.
Yes.
There is hepatosplenomegaly. Storage disease can be a possibility, which can present with even respiratory distress. Some of them, like Niemann-Pick's, involve the lungs, which can be infiltrative. Gaucher disease can present with infiltrative lung disease. It could be unrelated. The respiratory distress could be unrelated, of course. Congenital infections can also lead to respiratory diseases. So we need to consider all this. So we need to send up all this, as I said, metabolic diseases for the test for the metabolic diseases, test for congenital infections. Hematological causes needs to be ruled out, whether it is whether it's hyperplastic anemias or the hemolytic anemias. And in non-immune hydrops, we also have to keep it, even the mother is Rh negative, Rh normal, Rh positive. There could be other like Kell-Duffy, which could also sometimes present as
and the workup has
you'll have DCT ICT positive, so that it will be important to look for.
Yes, so before transfusion or anything, we should keep in mind that we can have a quick screening of IEMs by few drops of blood on blood paper, filter paper, and we can also diagnose many of the storage disorders now by dry blood spot, which Dr. and that is free, which we can do. So this can be screened in such cases where we are suspecting genetic etiologies of storage disorders. So What investigation, Parag, will you do for genetic causes? And if those are negative, then Dr. Satish, what other non-genetic causes would you think in this child? Because this child, I think, recovered this. We have just summarized the investigations. We will quickly go through.
So there was anemia with mild thrombocytopenia, HB was 11 and platelet were 1,08,000 with hypokalemia and deranged LFT with negative septic screen.
So basically, for non-immune, we'll first go for the basic workup to look for the CBC, albumin, that is very important with leaking is there, and definitely 2D echo, because the most commonly thought process we have to think about the cardiac or in non-cardiac hematological. So in cardiac, we'll go for that and to find out mostly the right-sided stenotic lesion or hypoplastic left heart or Epstein anomaly. Severe ECD-like situation will have that common, I would say more of a leaking phase in the child, that is hydrops in more than 2 compartment, and in associated with that we can go for the other parameter if the child is they are offering genetic if possible.
So Dr. Om Prakash, with this information and if other screen is negative, are you sure that this is non-genetic cause? We have Mohite sir dealing with so many patients in NICU, joined us as a senior pediatrician. Sir, your experience also, can we definitely say that this is non-genetic?
Genetic causes of respiratory distress, they are very, very limited in NICU settings. That is
no, sir. Mild hydrops and such case with severe oligohydramnios in late gestation with mild hydrops presenting and being managed in NICU. So whether we should, we usually do newborn screening and TMS and everything we send. Karyotype if we suspect any dysmorphism, etc. But in this child, will you suspect, are you sure
we should suspect, there is no doubt about it. See, all of your baseline screens are, but here additionally the hemoglobin is on a slightly lower side. They did look for congenital infection like torch infection. They did look for the structural congenital heart diseases contributing for hydrops. The baseline liver function, renal function also need to be taken care of. So if all the organ system function wise they are fine, then we should think of genetic contribution for this hydrops.
Because IM report of this child screening had come negative, and that is why the child is in follow-up. I mean the baby is in follow-up now. So the question still remains that, sir, whether this can be still genetic.
Few of the causes which we discussed like IM or storage disorders, coming as hydrops is extremely rare. So what you said, see, RH has gone since 1970s. People have started diagnosing antenatally. So now if I have to categorize, if you see the latest statistics, 20% are cardiac, almost 40% are idiopathic. So that is a category where you may do your genetic workup.
Yes.
I have seen a good number of cases who came with a GI anomaly, something like a malrotation volvulus, who landed up with a hydrops, which are just observed, and for distress CPAP was given, and second day they started getting distension. Somebody thought it's a CPAP Bailey, but actually it was a perforation. The malrotation volvulus, giant volvulus, and such kind of 2-3 cases we have seen. Congenital infection again is a hyped thing, I believe. I'm sure Dr. Bindu is there. How many congenital infection you see really in your practice coming with hydrops? Olden days it was, but nowadays I think it's well taken care of. So that is again not a very common thing.
So will you advise parvovirus and all these workups to every of these children?
Very rare, because even in preconceptional counseling, we ask for the rubella antibodies and all those. We give them, if they are not immunized, we immunize them, and many couple now come for preconceptional counseling. In my span of 22-23 years, I hardly come across any congenital infection, especially in cases of intrauterine death or stillbirth. In such cases, we do advise for parvovirus and all those, but then half of the time we don't get a very conclusive report of the infection per se. CMV, of course, CMV sometimes we get some reports, but whether it's conclusive will be
so because as you rightly said that idiopathic cases need a follow for genetic cause. We had one case, Dr. Om Prakash, anemia, thrombocytopenia, and now this patient has also been discharged from NICU. They are following with the child, but we got on genetic investigation chromosomal breakage syndrome, where the child recovered but has follow-up possibilities of thrombocytopenia intermittently or adolescent, since adolescent percentage chances of monitoring for leukemias has to be done. So such idiopathic things which babies have been discharged from NICU should be put on follow-up with further possibility. Still remains in mind that whether we should investigate such.
The infective cause, one thing I would just like to say, we are seeing a lot of adenovirus now. Almost each and every home has adenovirus. So whether this, because one of the cause is also mentioned as adenovirus.
Anomalies, not per se. Hydrops.
Hydrops.
Yes.
One cause commonly we have seen is the feto-maternal transfusion coming with hydrops. That's another thing. One more thing is the antenatal NSAID given to the mother pre-closure of the ductus. Antenatal, that's what gives rise to hydrops. So in fact, these are the causes which we see in clinical practice more often. The conventional which is described in the book, really we don't see that. Om Prakash is there, he will say, but these are the kind of causes. And at one definite take home is don't take hydrops lightly. Mortality is huge because many times you don't have a diagnosis. So unless and until proven, don't take it lightly.
Yes,
take it just, and then you will suddenly child will crash with pulmonary hypertension and refractory pulmonary hypertension. You may not be able to save it.
So that was the intention of taking this case, that in which cases you will wait for the genetic report, consider it non-genetic, but keep a high suspicion and put on follow-up. So there are some cases where you may not jump on genetic diagnosis, you just screen for hematological disorders, lysosomal storage disorders and IM. And if it comes negative, we have some few etiology genetic also, but we will keep in mind, and as sir said, they are difficult to manage. We will keep on cards and still keep some possibility that on follow-up if we get some finding.
Yeah, Snehal, we also see early hydrops in around 13, 14 weeks that what do you say with the cystic hygroma and all those.
There
yeah.
we have.
Then in those cases, like patient obviously opts for termination. So like we will definitely send to the genetic counselor. So what do you advise them and what all tests in
Yes, so
these
the early hydrops which are about to be terminated, Purandare madam is here, very difficult sometimes the tissue, getting tissue for karyotype and all. So in such cases, if it is very early hydrops, we are taking DNA. If it is very fragile, but otherwise we are doing karyotype and depending on the abnormalities, karyotype if it is early fish, then and DNA storage for investigation. So karyotype to rule out Turner syndrome and chromosomal abnormalities, and if it comes negative, we keep DNA stored after the termination and do for single gene causes of hydrops. Noonan is the commonest abnormality.
Noonan
seen,
syndrome.
In addition to, see, most of the single gene disorders will be diagnosed by sequencing because most of these are predominantly single gene diseases. I want to point out alpha thalassemia, which can be detected on HPLC of the, so we will see HB BARDs. So if it is a alpha thalassemia, it has to be done by a separate test. Exome sequencing will not pick up this test. You have to do a separate PCR test or an MLPA test for alpha thalassemia.
So DNA storage is important in cases of unexplained hydrops or abortions, which was present in this case, that unexplained abortion was there. And there we can do multiple testings depending on the suspicion or abnormality. Sometimes you have to do multiple testings because if everything is coming negative.
So the subsequent course in NICU, baby improved, repeat CBC was sent in which HB was lower, 10.10 and platelet improved to 140. Repeat 2D echo was done in which the pressure were gradually reducing and baby was extubated on CPAP and inotropes were also tapered and omitted by day 4 to 5 of life and maintaining well. This was the repeat X-ray was done on day 5 of life and feeds were started and baby was discharged on day 10 of life. So we planned investigation on follow-up like CBC, peripheral smear, LFT and RFT, but after that patient lost for follow-up, so couldn't assess clinically and do subsequent investigations.
So we have already discussed that what is the stand on such patients who have been discharged from NICU, but some guarded prognosis or follow-up, whether we should do exome sequencing and Parag, because now newborn exome and rapid exome is available. And Mohite sir is also there. We are seeing so many NICU patients, whether we should be sending newborn exome sequencing in such, not in this case, but severe cases which present in NICU.
Yes, I think there is where you don't have a very important non-genetic cause as the predominant symptom. Here we don't have any non-genetic cause as the predominant presentation, so genetics is possible. The diagnostic yield in hydrops vitalis could be quite high because hydrops vitalis when you're not suspecting the immune hydrops. When you're talking about non-immune hydrops, the diagnostic yield would be quite good. So there is a role of, you can do exome sequencing, you can do simple tests to start with if you're suspecting. Of course, preliminary investigations will help us. For example, if you're thinking of a storage disorder, you can do a bone marrow and see whether there are Gaucher cells or Niemann-Pick cells. Then you can do even enzyme assay if you're very strongly suspecting Gaucher disease. You may not need to do exome sequencing. You may do a sphingomyelinase assay or a glucocerebrosidase assay. If you're suspecting alpha thalassemia, you can do HPLC to see the HB parts.
But unexplained cases, would you
So if you
recommend?
don't have unexplained, if you don't have, then you do the screening of all the genes. So you have a panel of tests, usually a whole exome or a clinical exome. So clinical exome would cover about 8,000 known genes with known Mendelian phenotypes. And
so would you like to opt for a newborn exome, which is coming, rapid exome, which gives you 10 diagnosis within 8 days? In NICU cases which are severe, demanding final diagnosis to give prognosis or to help you further management. So what is your take seeing this availability of new investigation?
Just now. Hello, yeah, is there. I mean, you suggested those genetic testing and all. I mean, years for last one, I'm practicing for 32 years, right? So, IM workup used to be sort of an optional topic. Satish is there. For most of us initially, genetics was not existing then. Today, for everything we are onto genetics. And when I compare my clinical approach followed by the Nelson approach for IM, and then at the end of that, the yield coming out of all those tests, to date, it's hardly about 15 to 20%. Okay, so I'm seeing after 10 years, maybe by that time I may retire. But what is going to be future? Is it I suspect something and straightway send a clinical exome or a whole exome sequencing? Because cost by that time of all the investigation will be 5,000 and IM workup will be still 20 to 25,000. But main question remains, what will be the sensitivity and specificity of the clinical exome or whole exome sequencing you are offering? The phenotypic and genotypic correlates. Yes. Is it going to be that reliable to label something?
The problem in genetic testing is that unless we have a proper clinical phenotype which suggests a genetic syndrome, we many times don't get a final diagnosis. Our India, being a very heterogeneous population, we don't have common mutations for such syndromes, unlike thalassemia. Thalassemia, we have common genes, common mutations. But in many cases, we get variants of uncertain significance. So unless we have a clinical marker that this is a but many times the exome sequencing will help us to guide even what investigations to send. For example, if you get a variant of US in a storage syndrome gene, you can send that enzyme only. Because individually testing each enzyme may be more expensive. And sometimes you require to transport, enzyme assays are more difficult to test. Fewer labs are there which do enzyme assays. So this availability of this cell sourcing, and exome is freely available nowadays, with people offering it so many. So when you are very strongly suspecting, you must have some additional help also from the clinical investigations. Then only, for example, many of the sepsis syndromes could be primary immunodeficiency syndromes. So you have the CBC guiding us, the immunoglobulin levels guiding us, you have a flow cytometry guiding us. But sometimes these tests will take time. But nowadays these exome sequencing results come faster than these tests. They can come in 5 days also nowadays. So maybe a combination of these tests when you strongly suspect that it is a genetic syndrome would be more useful than doing for everything. Maybe tomorrow it might change if the costs go down further.
Cost and sir, whether...
Cost is going down day by day, the cost of genetic testing is going down.
Sir, if we get more data, and that is why the
Yes.
need of, as Dr. Satish said, sir, registry of such patients, NICU,
Yes.
where we have stored the DNA, we have a phenotype, and we, if the child, say, succumbs to the disease, then we go back and study DNA by doing exome. We don't apply it immediately. But if it is helping you for prognosis or management or explaining to the parents, you may take up in cases where you are on a borderline, assurance that whether you should go ahead. If definitive genetic syndrome, go ahead with newborn exome. No cause, everything is coming negative, but you want an answer, go for newborn exome with its limitations explained to the parents. But in cases where you are managing the child, getting little prolonged stay in NICU, IUGR and other things, you may opt for newborn exome with differentials in mind.
or you can store the DNA and do it later if child succumbs to the disease. So this is the current scenario. But recent conference we have discussed newborn exome. So more evidence, many NICU neonatologists are now jumping into the discussion whether we should go ahead with newborn exome and genome sequencing, and that would be, I think, recent national conference by Indian Academy of Medical Genetics discussed this issue, and they said that we in Indian scenario we will slowly go ahead, but we should maintain registry so that we can have more phenotyping of our patients and develop our own guidelines so that NICU neonatologists can get a help. Yes, so sudden aspiration.
Which we say does not exist. So could this have some implication? Do we have some kind of genetic disorders which
SIDS we don't have a data. The SIDS I don't think that we have, but then it again depends on the phenotype, Dr. Madhvi, that what are the, it was a clean baby and SIDS. Then you don't have any reason to just go for genetics because it was unexplained. But if you have some pointers, see clean baby in NICU, a premature baby, a clean baby, no sepsis, but maybe may not be growing or hemoglobin is less. Just because you want to explain something, taking up genetic test is risky. You have to have some factors to explain the genetic test. But if you are interested, that is what I am telling, that you can store the DNA and you can keep at hand when you follow up such babies. Because in one case we got Nisbeten-Breakage syndrome, which is benign. The child was recovered like this with eye drops. Child is absolutely well now, 6 months, 8 months on follow-up. But that is a Breakage syndrome which predisposes to adolescent leukemias and intermittent unexplained thrombocytopenias. So that is what we are explaining now to parents.
Unusual force. Like if a full-term baby with persistent respiratory distress not responding to the conventional ways of things. So we have got one with cartilaginous, and then we discussed one case with SIR also. We have got one with primary surfactant deficiency. So these are the cases which may have been missed otherwise, With genetics, we have got some conclusive evidence like this is the thing, and these are the things that in future that parents need to be keeping in mind when we are also communicating with them. So these are the places I will say we should think of genetics.
One more thing, in cases of SIDS that you mentioned, the cardiac arrhythmia syndromes, like long QT syndrome is also this. So sometimes even hydrops can be because of cardiac arrhythmias. So simple ECG also is very important. Many times they are investigated, but maybe we do not get anything. We had a family where they had multiple infant deaths. And one of the parents was carrier for a long QT syndrome, but it was affecting the babies more severely. And then the genetics was negative. Everything was negative, only the ECG was diagnostic. So sometimes DNA testing might fail, but the primary test would be of more importance. So that is the importance of clinical this.
Krina, you left. We wanted to thank you, Krina and Sheetal, for your presentation. And we have last panel discussion. He would change. They have changed the place. So we invite Dr. Tushar Jadhav and Moite sir is there to guide for this case. Dr. Om Prakash wants to leave for another meeting with NMOJS. Thank you, Dr. Om Prakash. Chintan, you have to leave. Sir, you want to sit, Dr. Vipin Pathak? No, he said that either me or Chintan, so you can participate in the discussion. Yeah. So you can come. Actually, we had requested him to be in panel discussion, but he said, yeah. If time permits, he will sit. So you will have to come, Moite sir, on stage. Yana sir, tumchis case. So thank you for coming and taking time. He was not sure whether he would be able to manage to come, but he's come. Dr. Moite is senior pediatrician at Panvel, and he has given few cases which Dr. Tushar will present.
Good afternoon, everyone. Good afternoon, panelists. This is Dr. Tushar Jadhav, consultant, pediatrician and intensivist at Moite Hospital, Panvel. So here is our case. The topic for the panel discussion: different clinical presentation of genetic diseases in NICU. So here goes the case 1. 27 years old, gravida 2, para 1 living with mother, delivered a male child of 3 kg weight by LSCS in view of previous LSCS. Baby cried immediately after birth, did not require any resuscitation, Antenatal history, there was no history of PIH, GDM, thyroid disorders, received 2 COVID vaccines, antenatal scans were normal. After 1 hour of birth, baby developed respiratory distress, hence referred to a pediatrician, where baby was kept on O2 by nasal prongs. The heart rate was 176 beats per minute, tachypnea was present, saturation was 87% on room air, and 95% on O2 by nasal prongs. CRT was less than 3 seconds, peripheral pulses were well felt. Systemic examination wise, respiratory system was normal, cardiovascular, per abdomen and CNS examination were normal. So for the panelist, what are the red flag signs in antenatal period that helps the obstetrician in anticipating respiratory distress in newborn?
See, here in this case, there was no...
The antenatal scan was normal.
Yeah. So if at all we see features of growth, the Doppler scans getting abnormal, Dr. Vipin can elaborate on that. When we see that, we see FGR, that is fetal growth restriction with Doppler scans abnormal. Then there is one red flag sign where we'll be, the neonatologist and ICU should be ready. And of course, if you are delivering her prematurely. Yeah, that also should be a red flag sign. And if at all during the like intrapartum monitoring shows any signs of like meconium is there, or the CTG is abnormal. When we are doing this cardiotocography, we see abnormal features which suggest an acidosis or hypoxia. Then also these cases we will have to be worry. But of course, there's other conditions like even TTN, like there is no cause there, but sometimes the baby doesn't like has some grunt or distress immediately after birth. So all these of course, and in diabetic mothers also. And hypertension, FGR, PIH, all those complicated pregnancies for that matter. Even with well-to-do pregnancies, during the intrapartum monitoring, if we pick up signs, and in complicated pregnancies like diabetes complicating, PIH complicating, or any for that other conditions, mother having any other medical disorders, all these cases we should be really vigilant.
Yeah. Going forward, so in our case, the baby had respiratory distress, so he was shifted to a tertiary care center and he was started on nasal CPAP. As the respiratory distress was persistent on CPAP, the baby was electively intubated and put on ventilator support. Chest X-ray was done, which was suggestive of low lung volume, and the FI2 requirement on ventilator settings was high. So what are the causes of full-term baby with respiratory distress with low lung volume on chest X-ray? So can you answer?
So respiratory distress with low lung volume on chest X-ray.
Chest X-ray.
So there are a lot of causes for low lung volume, like congenital aplasia can also be there. But what I said, these things will be cleared on the antenatal scan. Whatever the cause of low lung volume we are discussing, now we can rule out in antenatal scan because we see thorax, abdomen. So suppose there is cardiomegaly, some other abnormality in which lung is compressed, they can lead to secondary hypoplasia. And lung itself have hypoplasia. So full-term baby with respiratory distress, low lung volume on chest X-ray, in this scenario, we should consider some condition to the respiratory system and other system also, which can secondarily lead to hypoplasia. There is a broad differential for that, but full-term baby with low lung volume on chest X-ray, not diagnosing an antenatal scan, will be little difficult in this era, I think, because we will be getting that kind of scenario in the early pregnancy to know what are the causes. So these things we need to understand.
Mohit sir, like to add something?
I just want to know whether the lung is white or black.
The lungs are white.
So I have a reason. This is a collapsed alveoli. So it's like, could be a congenital pneumonia, could be some kind of pulmonary fluid, could be something like HMD. Now we have given a full-term baby. Full-term HMD is less likely, but polyhydramnios baby occasionally can have a HI, baby can have a full-term HMD, diabetic mother full-term can have HMD. So those are the kind of differential. Black or white will make a difference. Whatever he talked about are probably the black, and what I'm talking about the white lungs with a low volume.
Postnatal infection and whatever can be a cause respiratory distress. Okay. But congenital anomaly carrying to this scenario will be difficult. I think most of the scenario will happen after the birth. In antenatal, you won't get this kind of scenario where lung is hyperplastic and the pregnancy is carrying on. So whatever happen will happen during the time of delivery, and then this scenario will happen. So of course, what you said is the lung is void, then you can think of a lot of conditions which has led to
this child was a clean baby, I think 3 kg normal.
3 kg normal.
He had no previous PRM or any history in the mother.
No risk factors.
Because usually after 1 hour, within 1 hour you can think about hypoxia like perinatal, but right now after 1 hour we will think about TTN, which is commonly seen, but that will be resolved by 24 hours. If it is not resolving, getting worsen, so we need to think about early sepsis, which is commonly seen in our scenario because of some factors, and mostly the progressive disease of any respiratory or cardiac illness. In this child, we need to definitely monitor and see for whether is saturation or is not improving or not improving, because that will determine the pathology. If it is not improving, most likely it is respiratory. If it is improving with the inotropic support or other supportive, then maybe para-respiratory or not non-respiratory causes.
Okay. And there is diaphragmatic hernia. Those also can cause Bogdalex hernia, Morgagni hernia. Those can secondary also lead to distress if it is not diagnosed in antenatal. Antenatally, that's why I told you, it actually picked antenatally. So after birth will be something, after birth during aspiration or some kind of infection that can lead to that condition.
So I would like to add, sir, some diffuse developmental disorders of the lung, such as acinar dysplasias, capillary alveolar dysplasias. They can also present in a full-term baby with respiratory distress and low lung volume. Even a meconium aspiration syndrome can lead to secondary surfactant deactivation, and it can also present with low lung volume on chest X-ray.
Correct.
So we need to keep in mind these common scenarios also.
And another one is infant of diabetic mother.
Yes, sir.
Yeah.
Definitely, sir. So proceeding to the case, as the chest X-ray run was suggest of low lung volume, suspecting RDS, 1 dose of surfactant was administered. The baby improved drastically, the respiratory distress improved, and the patient was extubated to nasal CPAP the next day, and feedings was started. On day 5, baby redeveloped respiratory distress and oxygen requirement was increased. So what are the differential diagnosis?
This child, we have to think about cardiac causes also, where the child was improved with the surfactant, but it's not getting better after some time. So he has some associated problems like PPHN or maybe some associated congenital problems where child is not getting, like he is getting ventilated for some time, again he's getting collapsed lung. So we need to think about why getting recurrent collapsed lung, because in these cases sometimes like congenital problems with the lungs, what you have mentioned about acinar dysplasias or lungs conditions, we need to think about that.
So just one point here. This child was all right at birth. That's what you told me.
All right at birth, yes.
His distress started after 1 or 2 hours.
Yes.
So this particular history almost tells me something has happened afterwards, unless the child is neglected after birth. Nobody has seen the baby for 2 hours, which does happen still. So here is a problem which is sort of acquired after 1 to 2 hours. You take all the, like meconiums, you take HMDs, you take TTNB, they are breathless at birth. They are not after 1 hour, 2 hours. So those are kind of things I am sort of, what I can exclude I know at this point of time. This is a full-term baby, HMD less likely. No history of meconium aspiration, baby was normal at birth. Meconium less likely, HI this is not likely, TTNB again less likely, subsequently required a huge support, TTNB less likely. So what I'm left with, am I dealing with infection? But then you gave a surfactant and he showed a drastic improvement. So less likely to be infection. Now he responded to the surfactant, which is that full-term baby who responded to surfactant. Again, whether it is a HM diabetic mother, but again the baby should have been a breathless at birth. This is something which was, probably surfactant was there initially or what, worked for some time and didn't work. Fine, but he responded. After 4 or 5 days, he again offers to become bad. So is this infection catching up, pneumonia coming up, which is hospital-acquired pneumonia? He was still on, he was intubated, he was on CPAP. So hospital-acquired infection is the first possibility. Cardiac disease which will manifest on day 4 with a respiratory distress, a cyanotic out, unless there is a major shunt up like AP window or multiple shunts, out. Cyanotic, you are not telling me it's a cyanotic like presentation. It just became more breathless without significant oxygen requirement. Otherwise, drug-dependent cardiac lesion would come somewhere around 3 to 5 days. So that will be my approach in this case, prima facie. Again, I will have to see the X-rays, serial X-rays, how they are behaving. Maybe by that time I already done my echo on day 2, day 3 itself. So I ruled out any significant cyanotic shunts or something like that. So that will be a kind of an approach in this child.
As the baby was on CPAP and he developed distress, suspecting pneumothorax, chest X-ray was done, but no evidence of pneumothorax. So second differential was PPHN. So suspecting PPHN, 2D echo was done, no evidence of PPHN. But highlighting feature was some enlarged coronaries, suspected enlarged coronaries were seen. So enlarged coronaries during COVID setup, so we suspected MISN. So MISN workup was sent. Pro-BNP levels were raised, COVID antibodies were raised. So started on injection dexamethasone and IVIG. On day 12, baby was on CPAP with no improvement. So shifted to our NS unit. Baby had severe distress, so was put on mechanical ventilator. Chest X-ray was done. Chest X-ray was again showing low lung volumes.
What?
Enlarged coronaries.
Now we don't have the exact number. What is the things? Your exact size of it. Okay, Z score. So unless you tell me a Z score which is definitely there, otherwise this kind of an anecdotal. Now you do a COVID antibody for 100 mothers and 100 babies, 90% will come positive. So that really doesn't tell you. Okay. Now this is a scenario, in a post-COVID scenario, we will always have that as a possibility, and you are justified in giving IVG and steroid because it's life and death scenario. But is this COVID? One should be very careful unless and until I have a clear evidence of COVID, which will be a more than 2 Z score in one of the major coronaries. That's a cardiologist report. That's a cardiologist report. More than 2 Z score, more than 2. Okay.
So here is our case scenario. It's a full-term baby, transient improvement after surfactant administration, redeveloped distress, and persistent high requirement of O2, plus low lung volumes on X-ray. So suspecting congenital surfactant deficiency, HRCT was done, and HRCT was suggestive of patchy ground glass attenuation with thickening of interlobular septa, which is a finding suggestive of congenital surfactant deficiency. So for the confirmation, clinical exome sequencing was sent, and it was suggestive of ABCA3 mutations. So parents were explained about the poor prognosis, and hence they took DAMA. So I would like to ask you, what are the inheritance patterns of various surfactant disorders?
So there are
what are the clinical presentations?
There are primarily 3 genes. You have SFTP, I think SFTP-C, SFTP-B, and ABCA3.
Yes, sir.
So SFTP-C will present at birth. SFTP, the B part, the SFTP-B is dominant, SFTP-C is recessive, and ABCA3 also is recessive. So in this family history, whether any previous siblings were there who were affected, or any family members with interstitial lung disease, anything history is there, there is no history.
No significant family
so
history.
It is a sporadic case, it could be a recessive syndrome or it could be a dominant syndrome. The commonest is SFTP-C, which is the commonest. It accounts for more than for 60% cases. 30% cases will be B, and then 20% cases will be ABCA3. So in this case, what we found a third gene, ABCA3.
ABCA3 gene.
So this is recessive, so it needs to be, what was the mutation which was found?
ABCA3 mutation.
No, which was the type of mutation which was found? Can you show the report, please? I'll just see this. Yeah. So it was present in exon 12. It was a homozygous mutation, and it was glutamine 477 termination. So this is definitely a pathogenic mutation. So the mutation is classified as pathogenic because it is a termination mutation, and it is known that there are loss of function mutations in this kind of disease. Whereas in the dominant ones, you can get both missense variations as well as termination mutations. Treatments, of course, you will have to give repeated administrations of surfactants, which is a very difficult process. Lung transplant is another option.
Lung transplantation, yes, sir.
But getting a donor and everything is very difficult. So I think the prognosis is a little poor in this case.
Yes.
Lung transplant for such a small child is very difficult. Yeah. Yeah.
These are the various presentations.
Yes.
And we are getting viewers in such cases which have late presentation, where initially it was not suspected, but they still want to rule out the suspected mutations because it is treatable and mild. And then there is a problem when we get viewers in PC, especially those proteins which are peripheral proteins that Parag would agree where we find them. And there it is a dilemma where we are saying that we should have our phenotyping better and biopsy, sir. So because we are not doing electron microscopy and biopsy in such patients who are presenting late, mild, we are suspecting such diseases, we send exome, we get VUS, then we are slowly advising if we can do a quick lung biopsy, which is very easy. And sometimes, in such patients, whether we can do reverse phenotyping, sir. No, sir, I'm just saying that in such cases, we may have some patients are Sir, we have discussed in cases which were admitted in ICUs and poor prognosis, dying child, but mild presentation, and we started suspecting got VUS. So in that case, we can definitely advise, because parents now we don't do postmortem. So in such cases, we can do biopsy and phenotyping in these cases for the next pregnancy, when we have to re-phenotype and reanalysis of genetic.
For the biopsy, the problem is twofold. Getting the sample. And expertise to read the sample.
Yes, sir.
Getting the sample in pediatric patient also, as on today, is not. Now we are going for the laser probes.
Yes.
The cold and warm probes, with which we are getting a significant chunk, but still that is not the ideal one.
Yes.
So even in Vadia, when we need it desperately, we do open biopsy.
Yes, sir.
We do a mini thoracotomy and we will collect a small sample and send it. And then whom to read is the next big problem.
Yes, sir. So that
because
is why.
No expertise here.
Yes, sir. So that is why Parag and we were saying that there is so much of problem sometimes in working up in VUSs, where we don't have facilities, we can't do biopsy, we can't do electron microscopy kind of things. Then we have such a problem in re-phenotyping these cases, where your phenotype and clinical presentations and CT findings would help in categorizing our type of patients and correlating mutations in those patients, because working up our cases becomes very difficult.
Has this got any correlation in little older ILDs?
Yes.
Yes.
Some of the genes are known in ILDs. The dominant disease.
Yes, dominant disease.
Can you go back?
That is why I was discussing
So
this.
dominant, SPC is dominant. So you can get the parents may be having. So there is a lot of variable expression.
So
in the family you may have adults being affected and even
म्हणूनच तिथे VUS येतं, कारण की तिथे व्हेरिएबल एक्सप्रेशन असतं, आणि मग तिथे डुईंग दिस वर्कअप इज बिकमिंग सो डिफिकल्ट नाउअडेज. एंड देन वी डू parent is carrier because it is autosomal dominant. That is why phenotyping and our data become so important in such cases.
Moving on to the second case. 3 weeks old male child, first by birth order, born of third degree consanguineous marriage, resident of Panvel, was brought with the complaints of fever since 3 days, abdominal distension since 1 day, and decreased activity since 1 day. The fever was sudden in onset, high grade, not associated with rigors, no diurnal variation, no aggravating factor, relieved from some oral meds. On admission, the child was febrile. There's no history of any vomiting, but history of decreased urine output. Past history was not significant, family history not significant, except consanguinity. Birth history, full term, normal spontaneous vaginal delivery, birth weight 3 kg, baby cried immediately after birth, did not require any resuscitation, baby was immunized. On examination, the baby was febrile, tachycardia was present, RR was 56, peripheral pulses were feeble, CRT was prolonged. On systemic examination, cardiovascular system was normal, per abdomen examination revealed distension of abdomen with hepatomegaly. Respiratory system examination and CNS examination was normal. As the baby had features of shock, IV bolus, fluid bolus was given, but there was no improvement. So started on inotrope infusion. Septic screen was sent and IV antibiotics was started. the CBC set was suggest of hemoglobin of 12.3, TLC count of 12,200, lymphocytes of 70% and neutrophil of 30%. Platelets were 32,000 and CRP was 17.3. Lab investigations done was suggest of ABG, pH of 7.49, PaO2 of 66, PCO2 29, bicarb of 22, base excess minus 1.2, saturation was 94%, plasma lactate levels were 0.7, serum creat then was 0.38 which was normal, blood urea nitrogen was normal, SGOT and SGPT were raised. CSF examination was done as the child had decreased activity which was normal, and urine RM was also done which was normal. 2D echo done to look for the IVC position as the patient was in shock. The IVC was collapsible, cardiac contractility was good, there was minimal pericardial effusion. Ultrasound abdomen was done in view of abdominal distension which was suggestive of moderate ascites with hepatomegaly, but we could also find bilateral mild to moderate pleural effusion. So what's the thought process?
Any child with like a normal delivery, the presenting at 3 weeks, so we need to still think of late onset sepsis, or now like he had some infection process at the time of birth and is now presented, so we think of that. Second, any congenital abnormalities of non-infective variety, like he's got congenital infection of TORCH or any cytomegalovirus presenting with the first 1 month will be can, because the child had no significant history in the past or no current history. He just landed with a shock, and he had a features which is complete like multisystem involvement. Normally, hepatosplenomegaly is there. Even on the CBC, there is a biocytopenia. You raise liver enzymes are there. So there is a multisystem involvement of the disease, most likely to be sepsis in origin.
Albumin, serum albumin.
Serum albumin levels were normal. So moving forward, peripheral perfusion improved, urine output was adequate, so allotropic infusion was tapered and omitted. But fever was persistent, and provisional blood cultures was suggestive of no growth. On day 5 of admission, baby had altered stomach aspirates, stomach wash was given, CBC, PTINR and EPDT was sent. Now, CBC was suggestive of HB of 6.5, TLC of 2300, platelet of 12,000. PT was 16.6, INR 1.4 and APTT was deranged. So the baby was given a PCV and FFP transfusion. So what's the diagnosis?
He's getting like
persistent fever?
Yeah, he's getting worse.
Ascites, pleural effusion, pericardial effusion, pancytopenia, organomegaly. Is it infection or inflammation?
Infection is less likely because your parameters are not coming positive, and also the child is not getting better with the antibiotics. So he must have some associated either a metabolic problem or inflammatory problems.
So moving at suspecting inflammation, serum ferritin levels, fibrinogen level and bone marrow aspiration was done. Ferritin levels were raised, fibrinogen levels were decreased and bone marrow aspiration was suggestive of hemophagocytosis. So diagnosis of HLH was done. So considering the persistent fever, cytopenia, organomegaly, hyperferritinemia, hypofibrinogenemia and bone marrow finding of histiocytosis plus age of presentation plus consanguinity, a possibility of congenital HLH was considered and whole genome sequencing was sent, which was suggestive of PRF1 gene mutation. Perforin.
I would like to ask Mohite sir and Parag that whether can we do away with, because all parameters are suggesting of HLH, can we do away with bone marrow biopsy, because we are doing away with bone marrow, liver and tissue biopsies in many cases and directly sending genetic investigation. So what is your take?
So the criteria for diagnosis of HLH are clearly defined, which are 8 criteria of which 5 have to be positive. Bone marrow is one of those criteria. Then why we do it? Because that is doable, because 3 of the other criteria, CD25, genetic, so if genetic positive, it is HLH without any criteria. But otherwise, CD25, I think NK cell, and there is one more, which are not available to us. That's the reason we add bone marrow to fulfill the criteria of 5. Does it mean if you have 3, you rule out? You don't. You still send a genetics and confirm it.
Yes.
That's the only reason. Otherwise, this was a very black and white case of HLH which was coming up.
Yes, sir. I just asked this question because this question comes up in cases on late onset,
You
like
can do
where
flow
we
cytometry for this
flow cytometry
antigens now.
because
It
we
is
had,
available at IIH.
so we had patients in PICU where there was dengue also was suspected, some other viral infection and HLH. So whether it was primary, secondary, and the investigations were negative. So at that point, these were discussed in PICU that what can be done. So I just told them that you can store DNA, don't go ahead with the investigation unless you confirm whether it is primary or secondary. This is quite early presentation. But sometimes because primary we have to do because we have bone marrow transplants available nowadays. So there are criteria for a primary and secondary as you rightly said, sir. And in those cases, as you said that NIH, we can do the investigations, fill in those criteria and then they can call whether we have to do bone marrow or genetic investigations and go ahead with the investigations.
See, HLH we have been diagnosing or started diagnosing for the last 15 years and
Yes.
that has been a huge learning curve for us.
Yes.
So I still remember when 10 years ago, 12 years ago we diagnosed our first case of HLH, what was a 5-year-old child, and we gave etoposide to that enthusiastically. And that is supposed to be for primary HLH, not for the secondary. I would say if I take 10 HLH in my practice, only 1 to 2 of them are of the primary, 8 are of the secondary, and of that also, many of them are macrophage activation, not HLH. So there are 3 categories: congenital HLH, infection or inflammation induced, and third is macrophage activation. Where it is macrophage activation, only steroids. If it is infection induced or secondary, steroid with or without IVG, and if it is primary HLH, then etoposide modifiers and bone marrow transplant. That's how you usually go. So any child less than 2 years, you are justified in doing the whole investigation, including genetics. Above that, I don't think you should rush with the genetics.
So,
There
is it
are
take of
certain
susceptibility?
One more thing, there are certain syndromes of HLH
Yes.
with like Griscelli syndrome, which you can pick by pigmentary hair
So
exam.
that is very apparent. But what I am asking, as sir said that primary you have bone marrow transplant clear-cut criteria less than 2. But what is your take on some of the susceptibility gene disorders where a child comes and you get a susceptibility gene finding on that exome, and you are in a fix whether it is primary or secondary or just a susceptibility.
So unless you have clear-cut pathogenic mutations, most of these are recessive disorders. There is no dominant disorder there. So you should have 2 mutations segregating in the parents. So here it is a pathogenic non-mutation, so the diagnosis is not difficult.
But presenting late
So if it is
in PICUs.
So there are certain genes which are susceptible,
One
but
more
it is
thing
very
can be
difficult
done.
to correlate.
Difficult to correlate.
So you cannot do a proper genetic counseling for that.
Yes.
This cannot. There is no full penetrance of those diseases.
So one more thing we do is, as a screen is granzymes and porins upfront. That is available within 3 to 5 days, okay? And if that comes positive, very high likely chance that we are on a congenital HLH. If they are not there, then perhaps you can just hold on your rest of the investigations on genetic front.
And even as sir said, HLH and mass, that can be differentiated on bone marrow itself.
Absolutely, absolutely. Mass also you can have macrophage, we don't do. Actually, it's a clinical setting altogether. You've got a connective tissue disorder. Or sometimes you have got all your lymphomas and leukemias, they'll end up with HLH. It's an immune modification, not essentially primarily in HLH. It's a leukemia which by virtue of its immune dysregulation will end up with HLH. That's how it is.
So much of the questions were answered. So what is the HLH life expectancy and treatment quality, sir?
Just to answer that, but I think it depends on bone marrow transplantation. But it is a very fatal disorder. I think the mortality rate is very high. Maybe I think 70-80%. Yeah, maybe higher than
If
that.
not treated, 100%.
If not treated, then 100%. Yeah.
Yeah, 100%. That is why these questions of diagnosis come up.
Yeah, so
and
I
whether
think,
to start preparing patient for bone marrow transplant. Then if our child dies at 3 years, what to do if it is genetic and recurs in the next
Most
child? So there are
chemotherapies will be
unanswered
maybe
questions.
temporary. The chemotherapies will just give temporary response, but there will be a relapses also.
So I would like to add, we would like to start with the HLH criteria protocol, dexamethasone plus etoposide. Then whereas various immunomodulator drugs like rituximab, riloxatinib, alemtuzumab, they have been recently added, which we give the patient while preparing for the bone marrow transplant meanwhile. So as far as the bone marrow transplant is concerned, finding the exact match and then going ahead with bone marrow and the cost of treatment, all should be taken into consideration before giving the options. Thank you.
So we will have hematology genetics meeting. Hematology. I'm going to have it, sir.
Thank you, Sneha, for this wonderful meeting. And I'd like
Thank you
to
all
also
of
say
you for coming and especially Mohite sir वेळ दिला म्हणून आणि आले. So we want to felicitate.
Wonderful.
Sir, मोहिते सरांना सांगते फेलिसिटेट करा पॅनलिस्टला म्हणजे तुम्ही आलात म्हणून बरं झालं. Sir, adenovirus infection genomics. No, I have discussed with Awaeness sir about precise diagnosis of infections by genomics. We will be exploring. Sir, आहे त्याचं आलंय इन्व्हेस्टिगेशन सर आपण करूया ते. Adeno, influenza, COVID आणि हे सगळे एकत्र. Sir, Awaeness couldn't come, but yesterday only we have discussed that infection genomics.
We had second. And I'd like to also say Parag is was proper scenes throughout his MBBS and everything.
Thank you, Parag, Dr. Satish, Dr. Bindu, and Dr. for staying so late until last. We'll felicitate.
Welcome.